All right, let's see how we can get this to work. So bear with me. Whoop, that's not what I want. It's a great way to get started. Let's see if I can do this right. Probably should have done this before I actually hit record, but we'll see. All right, is this full screen for y'all?
Yes.
Perfect. Okay. Yeah, sorry. This is my first time teaching with you guys on the new platform. We were using GoToMeeting in the previous classes, and we actually had like a preview window that we could see what y'all were seeing, and this one does. This doesn't have it. As awesome as this is, it doesn't have that. So that's interesting. Oh, something like that. All right, this ought to be fun. So let's recap last night. What do y'all remember? Well, not last night, Thursday night. What do y'all remember from the first half of the patient assessment chapter? Because there's a lot to it, right? Sorry if I'm tagged in and out here. I'm trying to get a couple windows moved around.
Scene size up, primary assessment.
Okay. All right. So let's talk about the scene size up for a second. What three main priorities, right? Okay. So there's 6 different things that we look at in the scene size up, and this is always, always, always the first thing that we're going to deal with. So before you ever get out of your truck, you should already be starting this process. And there's 6 steps. All right. But every set of 2 steps in your primary, or I'm sorry, not your primary, your scene size up is actually just 3 priorities. So if you think about it, what's the first priority, no matter what? Who's number 1?
Making sure that you're safe.
There you go. So you're number 1. You got to take care of number 1 first. Because if you were to imagine, don't think of this as something small. All right. Your assessment is supposed to be something that you can use for a stub toe all the way up to 9/11, something of that sort. So priority number 1 is always yourself, because if you go charging into a scene that whatever it was that took out all the people you're trying to save, if that danger is still there and you go running in like a hazmat scene, now you're another patient. And not only are you one more patient in the list, but you also are one less responder that can get out there. So BSI, scene safe, that's your first 2 steps. And that is your safety. In fact, I'm gonna go ahead, before we get into this slideshow, let me change what we're sharing here. It's my sharing. Here we go. Cable. Share. Okay, can y'all see the whiteboard?
Yes.
Awesome. All right. So I just installed this right before the class. Bear with me as I get used to it. If I make some misclicks, I apologize. But we're going to move over here to your scene. We're just going to kind of go over what you've been over, and then we're going to talk about the scene, the patient assessment as a whole, and some ways that you can make it easier. Because when you look at those sheets that are out from the National Registry that we gave you, they're horrible. They are insanely hard. They don't make sense, not in the real world, and that's what has led to so many and forget it. But anyway, so looking at this, we have BSI scene safety, right? That's your safety. So if I've got the 6 steps here, and then underneath it, I wrote down your top 3 priorities in your scene size of it. Each one of these priorities gets 2 things. So if you can remember that, you'll nail all 6 of these right out the gate, and then you're just going to have all that momentum running right through your assessment, and you'll be done before you know it, which is how you want it to be. Because whether you're in school or in the real world, you really don't want you don't want to spend a whole lot of time sitting there going, all right, well, I'm gonna do this and everything, because your patient is sitting there having the worst day of their life looking at you, or even worse, they're dying, and you don't want to be wasting any time. Numbers 3 and 4 is triage. All right, so you know that you're safe. Now we got to figure out what we're dealing with. Again, this is supposed to be a one-size-fits-all assessment. So it's either your stub toe, it could be a bus wreck full of people. We don't know. So you may not always want to treat the first patient you come to. They may not need it. They may already be too far gone. They might just be too, it could just be a stub toe. Meanwhile, the next one after them is on their way to cardiac arrest. So figure out your number of patients. This is like a down and dirty triage. Figure out your number of patients and if you need additional resources. I know you guys talked about, having enough ambulances on scene or potential hazmat scenes if you need the fire department, the electric company, all that stuff. And then after that, now we're going to start to worry about the patient that we picked. So from here, here's a question for you. What's the difference between MOI and NOI? See who gets this right out the gate. Can y'all hear me now?
Yes. There's mechanism of injury and then nature of injury.
Close, yes. So MOI is mechanism of
Or
injury.
nature of illness. Okay, yeah.
Yep. So MOI has to do with trauma, and the NOI, your nature of illness, that has to do with medical. So depending on what you're dealing with, you may deal with one or the other. In the real world, you're going to sometimes deal with both at the same time. That's just how it goes. A guy has a heart attack driving 80 miles an hour down the interstate, hits a tree. Now you have the trauma of the car wreck and the heart attack that you're trying to deal with. So you may have to juggle both. In school, we're not going to give you that kind of a thing unless you're just that awesome. If I can't give you a challenge unless I'm throwing those kind of curveballs at you, then I might do it. So I can't tell you that I won't, but if I do, take it as a good sign. But you're going to pick it. If it's trauma, it's your MOI. If it's medical, it's your. And then the last thing is, even if it's medical, I want you guys to think about the fact that trauma may be involved. So consider that, all right? If you have a patient that had a stroke, and if they were at a standing position and they fell out and maybe they hit their head on the way down, that may be purely medical as far as what's going on and what you need to focus on, but you may still need to do C-spine precautions just because they may hurt their neck and that kind of thing. So that's the 6 steps of your scene size up. You can do this every single time. You can do almost all of this. In fact, you can do all of this before you ever make it to your patient. All right. So from the minute you get on scene, you're putting your gloves on before you get out of the truck, look around, see if you see anything that's a sign of an unsafe scene, determine whether you can make that scene safe or if you just need to wait until somebody else gets there. Then you're going to triage. Once you've triaged a little bit and figured out which patient you want to work with, then you're going to figure out what's wrong with your patient. So that's where the MOI and the NOI come in and whether or not you need to consider C-spine. You'll always consider it, but you may not always use it. Just because it says consider C-spine doesn't mean you're going to put a C-collar on every single person you come across. But just have that in your mind that you may wind up needing to. All right, so what comes after the scene size up?
Your primary assessment?
Primary, very good. So now you're at your patient. So these are going to be the first things that we do. Now, we base everything in kind of a priority list, and it's you can almost look at it as head to toe multiple times every single time you do this. But your first pass through the patient is always going to be your life threats. This is what's going to kill my patient in the next 30 seconds, a minute, that kind of thing. But how do we work on our patient? You've learned, we taught you ABC last class, but anybody who's ever had CPR knows that they're supposed to do CAB, right? Compressions first and everything. So at this point in your assessment, being that you're not just a McDonald's worker that learned CPR, you're actually learning to be an EMT. How do you know whether you're going to do ABC first or CAB?
Through your primary assessment?
Well, all of this is your primary. So whether you're going to do ABC, that's but your very first step. And you can actually, in this particular part of your check sheet, your checklist, we are having to go in order. So first step of your primary is determining their level of consciousness. Remember, and now that's a quick one. That's your AVPU. Are they alert, verbal, painful, and unresponsive? If you want to look at it like this, think of your level of consciousness as somebody falling asleep. So right now, we're only 10 minutes in the class. Hopefully nobody's falling asleep on me. We're all alert. But as you go hypoxic or as you lose blood or something gets out of whack, you start to nod off. So you're gonna go from awake, talking to people, just like we're talking to each other right now. Once your level of consciousness starts to drop, you're gonna start to get kind of drowsy. All right, and so now you're kind of nodding off. Somebody shouts at you or says you're, well, you can you respond to that. You may not be able to form a sentence, but if you say something to your patient and your patient groans or grunts or any of that sort, they're not alert, they're verbal. They're responsive to verbal stimuli. As they continue to nod off, now they're not getting to where when you talk to them, they're not responding to you. They're starting to snore. And so you walk up and you pinch their shoulder, or you do a sternum rub or something of that sort where you're causing a painful stimuli, and they respond to that, right? They grunt, they roll away or whatever. That counts. We like that. That's something we can work with. But if they don't do anything, then they are completely unresponsive. And if that's where you're at, if you get to a patient and you look at their level of consciousness and they are not responding to anything, you do a sternum rub, nothing happens. You pinch the shoulder, nothing happens. Check a pulse. All right, right now, we are kind of pausing our assessment and we're looking at whether or not we need to do CPR. So I want to know if because you don't want to check the airway and breathing right out the gate of a corpse. You really kind of just defeats, so you're wasting your time. So let's figure out if we need to do CPR or not. If they're not responding to you in that first step of your primary, your LOC, check a pulse. And where do we check it? We're going to go over some more of that tonight. I believe the vital signs we haven't gotten to yet. But if they're awake, we're talking to each other and somebody says, oh, my stomach hurts, I don't feel good, we can check a pulse in their wrist, right? If somebody's completely unconscious, most likely they're going to be dealing with signs of shock. Something's going to be going wrong. You can have a pulse. You're probably not going to feel it here. And if you remember from CPR, you only get 10 seconds to check a pulse before you need to be doing compressions. So where would we check a pulse if the wrist is not the best option? Good. All right. So the carotid, which is where? For anybody other than Sam, you know it, I know, but somebody else.
The neck.
It's on the neck, right? We're going to feel it. It's in that little soft spot between the trachea and the more meatier muscle that allows you to turn your head. So we're going to check there. You get 10 seconds. If you feel a pulse, fantastic. We can go ahead and continue our assessment. They are alive. They may be completely unresponsive, but we're not dealing with a corpse. So ABC, all right? If you feel a pulse, or if you feel for a pulse and in 10 seconds you don't feel one, we're just going to continue going down that CPR road where all of this stuff you're learning tonight it gets set to the side and we do CPR. And we always start CPR with compression. So now instead of doing ABC for your primary, you're going to do CAB, which is C is compressions, not circulation, even though it's kind of the same thing. So if you check their LOC, they're unconscious, go straight for a pulse. If you don't have a pulse, position, and you're doing 30 compressions to 2 breaths, singing Another One Bites the Dust, or maybe not out loud with the family there, but you're going down the CPR road. All right. It's not really what we're going to deal with tonight. You guys are going to get a whole lot of practice of making the choice of that fork in the road when you do your first boot camp. But tonight we're going down a conscious person's assessment. So you check your LOC, all right, and they're talking to you. We're going to say that they're awake and they tell you that their chest hurts, and that's what we're going to start with. So now we know we're just going to do ABC. First thing we want to do, and it has to be in order, A is airway. All right. So what do we worry about with airway? Somebody give me a quick down and dirty of what the airway entails.
You check to see if it's clear. It's like any obstruction in it.
Good. All right. And we're going to get more into that when we get to the actual airway chapter, which is coming up. But you want to make sure that the airway is clear, that the tongue's not in the way, that they're not gurgling on spit and blood and whatever may be in there. You want to make sure that you have a clear route from the mouth and nose to the lungs. That is your airway. It's the actual road system. So if the tongue's in the way, that's a occluded airway. If they're snoring, that kind of thing. All right. So airway is clear. All right. What is B? What does B stand for?
Breathing.
Breathing. Now remember, breathing is not necessarily the movement of air. That is your airway. Breathing is more about the actual respiration. So You determine that they can get air from the outside into the lungs. Congratulations, you have an airway. Can the body do anything with that? Some examples of that would be a no, would be COPD, CHF, which we're going to talk about, congestive heart failure, near drowning incidents where there's fluid in the lungs, any of those things. And there's a bunch. There's, well, I say there's a bunch. There's a few that we want you to know, but there's more out there as you go through your careers. But we want to make sure that the air that gets into their lung is able to get into their bloodstream, and that the materials that are in the bloodstream already are able to be exhaled back out. All right, what comes after B?
Circulation.
Circulation. Now, if our patient is awake, we're not really so much worried about circulation, like, do they have a pulse? All right, right now we want to make sure that the blood stays in the body, so they're not bleeding out on us. And we want to make sure that it's still going round and round, yes, but it's going to be, you know, if your patient's alert, you can check in the wrist, that kind of thing. But we're still concerned about life threats. If I told you, or you came across a patient that had broken their leg and they were in a motorcycle accident, so they've got a bunch of scrapes all over them and they're bleeding a little bit from a lot of their body, but it's not, it looks like blood, like you cut yourself shaving kind of blood. Is that a life threat that we need to worry about in the primary?
No.
Depends,
Not-
right?
Sorry, say again.
It all
Oh,
depends.
You broke up. Try that one more time.
I said it all depends of the severity of the blood flow.
It does. But again, right now in your primary, you're worried about your life threats. So it might be something you need to fix pretty quick, but do you think they're going to bleed out in this amount of time? And we're going to really talk about that in trauma, where how much blood is too much blood. All right. But right now I want you to think about, does it look like they might need Band-Aids, or does it look like something out of the horror movie It, where you've got blood stains and spatters on the walls and you walk in the room when you have to dodge the Spider-Man shoot, point his arterial bleed at you. They've done that. Fix me, and they're shooting blood. But that's something you want to fix in the primary, right? Where it's a massive hemorrhage, or you walk in and there is more blood on the ground than you think they could possibly hold in their body. That's a problem. So that's what we're going to fix in the primary assessment. Okay, so again, we're only worried about the life threats. And again, you're not trying to fix all the bleeding. You're not trying to fix every little thing right here. This is just, I want to make sure that my patient's not going to die on me before I figure out what's going on. All right. So once we get done with our ABC, and you know that they have an airway, using their airway, and they're not bleeding out, right? So the air goes in and out, the blood goes round and round. As long as that's happening, then we're all good. So once the primary is done, we move into our secondary. Now, the thing I want to talk about with the secondary, now I'll show you guys this. Unlike your sheets that you got from via the registry and what they're going to assess you on, those sheets have, it's all one list, and it says everything from BSI and safety all the way down to reassessment, and it's just in a straight line. But that's not, I don't like that. That's a bad way of writing it down. I get it. They had to put it in a checklist format. It was all they could do. But I want you guys to kind of look at a flow chart. So you can always start off with your scene size up. We're going to go through the 6 steps that we talked about. Then you do your primary, and same thing, we go through all this, well, not 6 steps. You're going to go through your 4 steps of your primary, like we talked about. Once you get past your primary and you know your life threats are good, now you get to kind of pick and choose what you're going to do in the order that you want to do it based on what you see in front of you. So you have your vital signs, which you're going to talk about tonight, your history, which you're going to talk about tonight, and your head to toe or your body system exam. Now, your head to toe is for trauma. That's where you're, or an unconscious patient. You're doing a literal head to toe. So you got to expose them, shirt comes off, pants come off, all that stuff, to make sure that you're seeing all the injuries they've got. Or if it's even in medical, if they're completely unconscious, you may want to do this, because what if it's an allergic reaction or something bit them or something? You want to see if you can see any kind of injury like that, because that could, well, what if it's a snake bite and you don't know? You just happened to cross somebody in a park and you got to take them to the hospital. You look around their feet area or something like that, to see if you see puncture wounds. These are the kind of things that you would look for in medical, but usually, at least in class, I want you to do head to toe with trauma, not really medical. Your medical calls that we're going to teach you are basically diabetics, heart problems, that kind of thing, about the body systems. If I give you a cardiac call, I want your assessment to be tailored toward cardiac. If I give you a diabetic, I want you to think diabetes, that kind of thing. But your head to toe your body exam, depending, your history and your vitals, you can pick them however you want. If you want to get your vitals first, fantastic. Get your vitals first. If you want to do your history, you can get that first. As you get more accustomed to it, you're going to start to find there will be days where you want to do it in a different order based on what you see. While you're learning it, whatever you want to do is fine. They're all on the same level. The only thing that I say is if you're going to start vitals, finish vitals first. Don't do 2 vitals and then get 3 questions and then go and do the head exam and then go back and get another vital, because you're going to lose your place. You're going to forget what vital signs you've already got. You're going to forget what questions you've already asked. And then you're going to start missing things while your evaluator is just sitting there looking at that sheet going, and we don't want that, right? So you choose what you do first, but finish it before you move on. And then once you've got all 3, then we're going to do our reassessment. Don't know if he's already mentioned it or not. Let's see. If it's an unstable patient, how often do we reassess?
Every 30 minutes.
No. And even a stable patient's half that. So it's going to be either 5 or 15. All right. If they're unstable, think about it like this. If they're unstable, we don't want to wait 30 minutes or 15 minutes to figure out that their vital signs crash. So we're going to check them more often. So every 5 minutes. All right. If they are stable, let's say you get called out, because I've had these calls before where they had a stomach ache, but it was 3 days ago. They've been fine. They just at 5:30 in the morning, the next, 3 days later, decided they wanted to go to the hospital to get checked out. But there's nothing wrong with them. They just a little worried. Sometimes it happens. And that's the kind of stuff that a lot of times we'll talk about in a not very positive way, but it is an emergency to them, and that's what matters. If they're stable, though, we don't have to check them as often. Every 15 minutes is fine. Now, I'll say this. In class, in your assessments, in your testing, every single patient will be a high priority. We're not going to give you a stub toe, because then we can't really assess how you're doing. We're only going to give you the not really the worst of the worst, but we're going to give you unstable patients. So you can pretty much bank on, if anybody asks you how often you're going to reassess, just say 5 minutes. When in doubt, go with 5 minutes. You won't be wrong. It's better to do it too often than not enough. All right, so as you can see here, I wrote secondary assessment is your vitals, your history, and your physical exam. You can do them in any order. So now we're going to talk about the actual secondary assessment, which I like to say the secondary assessment is everything after the primary. It just makes more sense to me, even though your actual checklist label is a little bit different. Now, I know we're not really going off the slides here, so when we get done with this and we switch to the slides, I'm probably going to start clicking through a bunch of them. Let's talk about your vitals for a minute. Vitals that we need on absolutely every single patient are going to be your blood pressure, your pulse, your respirations, all right, your O2, and your blood glucose. Now, your glucose, if I'm sitting here perfectly fine talking to you, you may not necessarily need to get a glucose on me. But if I'm not in my right mind, confused, if there's some level of this, if you find out I have a history of diabetes, anything of that sort that makes you think something's wrong with the brain, get a glucose. All right. But the other 4, your blood pressure, your pulse, your respirations, and your O2, 100% of the time, every single patient, make sure you get that in class, make sure you get that, because those are massive, those are major. And when we get to certain chapters later on, we're going to start talking about how those vital signs actually matter to the body. So they're not just a set of numbers. I want you guys to be able to look at a set of vitals and be like, that's not right, that's a head injury, or, oh, look, I see signs of shock starting to form, that kind of thing. All right. For your excuse me. All right, so let's talk about history. First one we're going to talk about is sample. Did anybody study ahead? Have y'all finished reading the chapter?
I didn't get a chance to read it this time, so no for me.
Okay, that's fine. I know we're all busy. Anybody gone over sample, read ahead, seen sample, or OPQRST, anything of that sort?
I read a little bit.
Okay, awesome. I just want to make sure that I'm not speaking Greek to anybody when we go over this. So we're going to start with sample. These two mnemonics are meant to help you remember what questions you're going to ask when you get to your history. So when we're dealing with sample, you can ask sample on every single patient you come across. The questions are going to apply no matter what you were called 911 for. All right. OPQRST, not necessarily. OPQRST, you're going to ask about anything that you can't quantitatively measure. So, for example, if I'm in a car wreck and I broke my foot, you can see why I'm in pain, right? I tell you, ow, I broke my foot, and that's my only complaint. I really don't need you to ask me about questions of the pain when you can see what why it hurts. You fix the foot, get me to the hospital. But you can still get a sample, all right? And you should always get a sample. If I told you my stomach hurt, can you look at me and be like, well, I can see why your stomach hurts? Or if I told you my chest hurt or something of that sort. A lot of your medical calls are going to be where you're getting the OPQRST questions, because those are questions that are designed to give you more information about something that you can't necessarily deduce on your own. That being said, you can sometimes get a sample from somebody who's unconscious. Somebody who, like, if you show up and it's an elderly male having a stroke and the wife is there or the husband is there. A lot of times they know the medical history. They know what their spouse's allergies are, or if you're dealing with a parent, they know what the spouse's allergies are, stuff like that. But you can only ever get the OPQRST questions from the patient directly, because they're all questions about how that person feels. You're trying to ask questions that give you more information about that pain. So we're going to start with sample. All right, so you've gone through your assessment, and if I got time before Chris jumps in and throws me out, we'll do some practice. But let's talk about sample. So S. What does S stand for? It's on the screen.
Symptoms.
Signs and symptoms. All right. You can also, if it's medical, you can look at S as story, where you're going to get the signs and symptoms and you're going to ask them what happened, right? All right. So what's the difference between signs and symptoms?
So the signs are like the physical, like, characteristics that you can see, and the symptoms are information you obtain from the patient.
Exactly. So OPQRST questions, are they going to be signs or symptoms? Kind of getting into what the questions are at the moment, but if you're asking about somebody's pain, which is what the OPQRST questions are you getting signs, information and signs, or information and symptoms?
Symptoms.
Symptoms, right? Because those questions are about pain. You can't see pain. You can see somebody maybe in pain, but you can't look at the pain and be like, I can tell from looking at you that that's a sharp pain or a crushing pain or something like that. So those have to do with symptoms. I put a question in the Discord earlier in the communities study hall because somebody asked for some registry questions. And one is this, here, I'll even read it to you. Give me a second. It's which of the following is a sign of a heart attack? All right, so your options, so let me get to it. All right, which of the following is a sign of a heart attack? Chest pain, epigastric pain, lightheadedness, or sweating?
Would it be D or C? I'm thinking, because that's physical. Sign.
Remember, there's something you can see. Can you see? Can you actually visibly see chest pain on somebody?
You can't.
No, they have to tell you, right? They have to tell you they're in pain. Like I said, you might be able to see that they're in pain in general, but you can't see chest pain. You can't say, oh, he's gay. It's definitely the heart. I can look at it and see it. Can't do that. What about epigastric pain?
No, can't see it.
Same thing. Epigastric pain, kind of to put that into layman's terms, that just means pain centered and a little low in the chest, right? It's above the stomach, but it's in that area. That's what gastric means. All right. Lightheadedness. Can't really see lightheaded, right? Somebody is sitting down. If they're standing up, trying not to fall over, they look dizzy. Maybe you can see that, but you can't see the lightheadedness. They have to tell you they feel lightheaded. But sweating, especially sweating on the scale of a heart attack, that is diaphoresis. That is not just a light glisten because it's warm in the room. They are pouring sweat. They are practically a sprinkler system. You can see that. You can absolutely see that from the other side of the room. And usually that's one of the signs where you walk in and you see them, they don't even have to open their mouth. You're like, all right, yep, we're going to the hospital. Let's go. Because that's not normal.
So when they ask a question like
All
that,
right, good.
registry. So when they
Mhm.
ask a question like that on the registry, they're wanting to know like the physical, like what can you see when they say signs? Unless it
Yes.
states in the
And
question otherwise.
yep, if they know the difference. So the question, as I worded it in the Discord, is exactly how it showed up on my registry when I became an EMT. I remember it to this day because it almost got me. I saw that question and I was like, oh, well, it's going to be, first thing I saw was chest pain radiating to the left shoulder. I'm like, right there, that's a heart attack. So I clicked it. Right before I clicked next to go to the next question, I was like, wait a minute, that seemed too simple. So I went back and read it again. And it said, which of the following is a sign of a heart attack. So I went through and I read all four of them and it just barely caught it. Only one of them you can actually see. It didn't highlight, it didn't underline, it didn't capitalize sign. It didn't do anything to draw my attention to the fact that it was not asking. It just said, which of the following is a sign of a heart attack. And that was it. And I had to catch that. So pay very close attention to your registry questions because they will get you. You could teach the class yourself, as far as what you know, but if you don't catch those little gotcha moments, you could still fail that test.
So what was the answer?
The answer is sweating. Of the four options that I put into that question, only one of them you can see from across the room. And it's sweating. The rest of it, the patient's got to tell you. They would tell you that they have stomach pain or chest pain or something like that. You might see that they are not comfortable, but you can't actually see pain, right? Like think about it. If you get a bruise or you hit yourself before the bruise shows up and you're like, ow, that hurt. You know it hurt, but somebody on the other side of the room can't see that. All right, we got a raised hand. What's up?
A quick question. I mean, it may be off topic. So for the registry, I've been taking like practice exams. It's more like scenario questions. So like, what is your advice, I guess, when it comes to take that test? It's more like scenario questions, right, on the registry. What would you do?
Okay. This chapter right here, master this chapter right here. All of your scenario questions in the registry give you a scene and you have to put yourself in your assessment. And remember, your scene size up and your primary assessment are done in order. The rest of it you can finagle. But if you get questions that say, like the one before that one I put in, I was like, you have a patient that he's displaying this, he's got these vitals, this is what you're seeing. What's your first step? All right, so you look at, the one that I gave was a diabetic. So you're gonna have to put him on oxygen. You have to make sure he's got a good airway. You're gonna make sure, give him some glucose, oral glucose if you need to. And we're gonna learn all that when we get to that chapter. One of those options that I put in there are valid answers. You would probably do that in that scene, with the exception of the glucose, because I put in that your patient was responsive to verbal stimulus, which means that he wasn't alert. So that's a heads up, right? If you look at your assessment, one of the first things you're going to do is check your LOC. Well, if he's not alert, you will have learned by then that you're not going to give anything by mouth because they could aspirate it. Then you have your patient in that question, I gave him snoring respirations, which means when you get to airway, you're going to learn that that means the tongue is occluding the airway. So you don't want to jump to B until you've cleared the airway. So again, now you're saying, all right, well, I'm recognizing that all of these are things that I would do eventually. But the question is not asking which ones of these will you do eventually. It's asking what you're going to do first or next. So you have to, using your assessment, rank the order of the things you're going to do. That will help right there. And then make sure that you can do what that option says. Again, I gave you a patient that wasn't alert. You're not going to give him oral glucose, even though that is the absolute definitive only thing you can do for a diabetic. But if he's not alert, you can't do it. So you throw it out, that kind of thing. Yeah, know your assessments, know them in order. You don't want to just learn this for skills. You're going to have to take this with you to the registry. Otherwise, you're going to miss almost every one of the scenario questions. That's one of the biggest things out there. And that's why all your answers look right. You're like, wait a minute, I'm going to do all these. All right, but anyway, back on sample. So after signs and symptoms, we have A. All right, A is for allergies. So again, this is one of those questions you just ask them, like, are you allergic to anything? All right, and they could be drugs, medications, food. You want to get it all, because some food allergies will stop the hospital from giving certain meds. Egg allergies, iodine allergies, those kind of things will affect certain meds. Certain meds will cause your patients to have allergic reactions. So it's not just about drugs. I want you to get a full allergy list if they know it. If they don't, but they don't know, that kind of thing. All right, M is for medications. And this one you can actually spend a little bit of time on. So when you're talking about meds, we're not just referring to what are they prescribed. I want to know, what do they take over the counter? If it looks like they're on steroids, probably not going to tell you that they're on steroids just because that's illegal. If they're whatever, that's fine. You're not the cops. Let them know that. Maybe they'll open up to you. Maybe they won't. But you want to know what they're supposed to be taking. You want to know what they've decided to take. And you want to know if they are taking what they're supposed to be taking. So for example, if you show up to an elderly patient with a heart problem and he tells you that he takes blood thinners, you can follow that up with, okay, when's the last time you took them? Have you taken your medicine like you were supposed to? So kind of paint that picture. You want to get the list, but you also want to know if they're what they call it compliant. Are they compliant with their meds? Because if they, for example, if it's a heart patient, he tells you that he's on labetalol or something like that, but he hasn't taken it in 3 days, well, that's probably why he's having his problems. Or another one, if it's a heart patient, they know they have a heart problem, one of the things you're going to learn to give in your cardiac chapter is nitro. One of the questions you want to make sure you ask before you give it is, have you already taken it? Because they can only take up to 3. So aside from the whole slew of other things you want to know before you give that med, you want to know if they've already taken it. All right. After that, pertinent medical history. And I say pertinent rather than past, because I don't really need to know if somebody broke their ankle when they were in 2nd grade, or the time they flipped out the swing backwards in preschool and landed on their butt and broke the tailbone, or whatever. But if they lost their appendix, I might want to know that. If they are complaining of chest pain and they are a heart patient, I want to know that. That makes sense, right? So you want to ask them their history, but don't let them go off down the rabbit hole with it. You're going to have to rein them back in if they start talking about stuff that has absolutely nothing to do with what you're looking at. Ask them what they ate, all right? Because we always have the risk, especially if it's medical, that it may be food poisoning. We also run the risk of it not being food that they ate. And then also, if it's trauma, for example, what fixes trauma? Can we fix trauma in the field? Can I actually fix a broken bone?
No.
No.
No, you cannot.
Right. We stabilize and we get into a hospital. Surgery actually fixes trauma. So if you're going to go into surgery, you're probably going to go into anesthesia. And anesthesiologists want to know what you've eaten and how long ago you ate before they put you down, if you can get that information, because they don't want you making a mess of the OR and regurgitating all kinds of stuff when you're digestive tract starts shutting down. So if you can get that information. And then E is the fun one. E is events leading up to, like, what happened. And if it starts with, well, I had my friend hold my beer, you're in for a trip. But you can get a sample on every single patient that you deal with, even if they're unconscious, but somebody's got to be there to answer the question. So for class purposes, for example, if I give you a conscious patient, you can ask that patient. If I give you an unconscious patient, you can start off with saying, okay, is there anybody here that can answer these questions? And if I say no, I'll usually follow that up with, but what does sample mean? Just so that I can see you go through the list and tell me what it is. All right. The other half of your history, make sure I don't take you guys over your hour for your break. Other half of your history is OPQ. And again, that is questions about something that you can't see and quantitate on your own. So somebody kind of tells you that they're in pain. That's a really good one for OPQRCs, where you're usually going to use that. If I told you my stomach hurt, go to OPQRST, get more information, because there's so much stuff. That's another long chapter. When we get abdominal injuries in the medical side of the house, it's going to take a while, because we're going to talk about appendicitis and pregnancies, ectopic pregnancies, and food poisoning, different issues that can happen with your intestines, spleen, all these, kidney pain, all that stuff. How do you know what anything is hurting if all you have is my stomach hurts? So that's where these questions come in. Anybody tell me what O is?
Onset.
Onset. All right. So these questions, I should also let you know, are open-ended questions. All right. This is where you just want your patient to have diarrhea of the mouth, as long as it's pertaining to what you're asking, because you want their words on what they're feeling. You want to be careful not to lead them down the rabbit hole. Like, for example, when you want to jump ahead a little bit in this one, when we get to quality is, what kind of pain is it? All right. Now, what I expect patients to tell me is describe this pain to me. They're like, oh, it's sharp, or it's intense, but it's kind of like spread out, or it spreads around, that kind of thing. Or I feel like I'm being ripped apart. That's a specific one we're going to learn. But you don't want to be the guy that's asking your patient, is it a sharp pain? Yeah, it kind of is. But now that leads you down the wrong road. So let them, even if they struggle to find the words, let them be the ones to tell you how it feels. So onset is, what were you doing when this happened? So it kind of ties into E from sample. They're about the same. All right. If you want to know that he screamed out, I am a living God, but off of his roof and missing the swimming pool, that would happen, and that you get that information in O for onset. All right. What about P? What does P stand for?
Provocation.
Okay. Provoking, provocations, and I always write provocation, but it's what you get it though. So that is, does anything make it better or worse? You're going to get that a lot in your abdominal pains. People are going to tell you it feels better if I press on it, or it feels better if I'm in this position, or if I don't take too deep of a breath, whatever. But it goes either way. You're asking questions about, what does anything make it better or worse? What about quality? And we just kind of talked about that one.
You were saying, like, what's the quality of pain? So I'm assuming, like, is it intense, or can you rate on a scale of 1 to 10 the quality of it?
Yes. Well, not the scale. That's going to be the next, or that's severity. But for quality, it's describe this pain to me. For example, think about some different pains that you've had in your life. Particularly, I always go to the abdominal pains, because there's so many different ways that you can be like, oh, my stomach hurts. All right. Ever pulled a muscle?
Yeah.
That hurts really, really bad in a very small spot, right?
Mhm.
Kind of feels like you're being stabbed wherever that pain is at. What about food poisoning? Anybody ever had food poisoning? Oh, you are fortunate. You were really fortunate. Wow, nobody's had food poisoning. All right, well, think about this. A general stomach ache. Just, oh God, my stomach hurts. Is that really, really sharp, or is it kind of like my whole area? Like, it could be intense. I'm not saying not intense, but it's not like it hurts right there. Right here's fine, right here is fine, here's fine, here's fine, it hurts right there. All right, that's sharp. Blunt is filled with a regular stomach ache, and it can be like, it just, this whole area hurts. It's real bad. It's a 10 out of 10, whatever, but it's this whole section hurts. That's kind of what you're getting at there. And there's a reason for that. If you think about if we go back to chapter 6, when we learned about the anatomy, it was 6 for y'all, right? 7 for advanced EMTs, but organs don't have a lot of pain receptors. They're not really meant to feel pain. So the body's not going to grow a whole bunch of pain receptors to them. So if you picture any organ that's in your abdomen, if you can pick one spot where you might have some inflammation, the next closest pain receptor to it may be over here or over here. An extreme pain, but it feels like it's spread out because the pain receptors are not tightly packed like they are in muscles. They're kind of spread. There's fewer of them. So that 10 out of 10 pain may be the entire right side of your stomach, depending on the organ, something of that sort. If it's a visceral pain or a muscle pain, so you pulled a muscle in your abdomen, you stretched wrong, or you jumped off your roof, or something of that sort. That's gonna be sharp, right? Your muscles they're more meant for movement, they're more meant for feeling things. You're gonna have a lot more nerve endings. And so that pain is going to be much closer together. So that's kind of where it could be me too. If I don't know if y'all can hear me. It hasn't yelled at me in a little bit. I don't know. But anyway, hopefully it works for you when you log back in. The muscle pain, things like that tend to be sharper pains. They cover less square footage, basically, less real estate. All right. What about R? What is radiation? What are you going to ask about that?
Is it just localized or is it throughout different areas?
Okay. Yeah, so R and quality kind of go hand in hand, because one of the questions about quality might have been, does it feel diffuse? Does it kind of spread out? There's a difference. So in the sense of a stomach ache, just being that it takes up an entire quarter or a half of your stomach doesn't necessarily mean that it radiates anywhere. It's diffuse, it's covering an area, but it's one area, right? Think about your kidneys. Your kidneys they're going to cause a stomach ache, but you also get flank pain that hurts around kind of behind you. The reason being is because your kidneys, whereas most of your organs sit kind of front half of you, they're in your gut. Your kidneys are back behind you. They're closer to your back. So organs, again, don't have a lot of pain receptors. Further away, you're going to pick them up, which means that the receptors in the back are going to pick up the pain from the kidneys. You kind of get that feeling like they're stretching around to the back. What about heart patients? The heart itself, again, doesn't have a whole lot of pain receptors. And our hearts sit, a small percentage of the population is different, but most people's heart sits like this, angles down to the left. So if my heart's in pain and the nearest receptors are over here in my shoulder, I'm going to get that radiating pain coming over here. Usually for men, especially, we feel that pain kind of radiating down our arm. It catches those nerves that run down. And so we'll feel the pain kind of starting here and going in that direction. That's, again, all these questions are designed to help you try to figure out what's going on. If I just told you my chest hurt and that was it, you don't really know whether to give me nitro or Tums. These questions kind of help figure that out. All right, what about severity?
Like you said, on a scale of 1 to 10, so I guess how intense is it, or how bad does it hurt?
Good. Now, scale is actually 0 to 10. All right, I'm not trying to be nitpicky, but if you see it on the test, I don't want you to miss that. So you might not be in any pain. So you could be a 0. Granted, you really wouldn't be asking questions if they were in 0 out of 10. So there's that. And a patient's very rarely going to tell you that it's not a 10 out of 10. Because again, if it was something moderate that they could manage, they probably wouldn't have called the ambulance. So you're more likely going to often hear 10, even if it may not look like a 10 to you. But remember, I don't want you guys to get that mindset that a lot of people in the field have, where it's like, oh, they're just big babies or whatever. No, if it was bad enough for them to call 911, even if you think you wouldn't be in a 10 out of 10 pain, to them it may be the worst pain they've ever felt. It's all subjective. Because what is 10 out of 10 pain? Is 10 out of 10 pain a shot to the face, or is 10 out of 10 just the worst pain you've ever felt? You guys that have never had food poisoning. So just a thought, right? It's subjective to the patient. And then T is for time. Time is just basically how long has this been going on? Time is a critical question in strokes, because a lot of the medications that we give in the hospitals are time sensitive. If they've been having these issues for over 12 or 24 hours, depending, they're not going to get some of the meds because they're not going to work. So you want to make sure you get that question. And depending on, when we get to the chapter, that's gonna be one of those times where we tell you, you may not ask the full OPQ RST, but you got to get the time. So you can pull that one question out of the mnemonic and ask that question, at least that question. All right, because that's going to be one of the first things the ER asks you when you roll in the door is, how long have they been in this? Because they need to know that. All right, and so going back to the assessment here overall, so we've gone through our scene size up. We got 10 more minutes and we'll take a break. We've been through our scene size up. We've been through our primary. We've talked about vitals. We talked about history. So the other thing I want to talk about is your head to toe or your body system. And we're not going to get too deep into the weeds because there are entire chapters dedicated to this when we get to trauma and into the medical emergencies. But I want you to know that your actual head to toe is meant for trauma. All right. And your body system, if somebody tells you they have a stomach ache, you're really not going to start poking and prodding on their face. It really doesn't make any sense. So use common sense in that sense. If they tell you their stomach hurts, you're going to do the body system check, which is where you basically just ask questions and you start to narrow down what is actually causing them to be in pain. And then you're going to start to make your treatments based on that. You're going to go down your heart attack medications for the heart attack patient, but you're not going to give it to the guy having a stroke. Or, you give glucose to the diabetic, but you're not going to give it to the one having the allergic reaction. It doesn't make sense to do that. So that's what your body system check is for, is to make sure that you're treating what is going on, even though there may be 10 different things that cause altered mental status. You're trying to narrow it down. All right, but your head to toe, your specific head to toe that you'll learn later in the class, that is mostly for trauma, because you're trying to survey the injuries. So again, the order that you do these in is entirely up to you. When we start getting into those chapters, you're going to learn in medical, you may want to get your history and your vitals first. But in trauma, I actually tell people always start with the head to toe. Like if you want to just continue to put things in order, when you get done with your primary, just do your head to toe, because you can't move your patient until you know what their injuries are. You find that out in the head to toe. You can do your vitals and your history in the truck on the way to the hospital, but you need to know how to move your patient so you don't make a broken bone worse or something of that sort. But again, it'll get easier and make more sense as we go through. And then again, once you've completed everything, we end with, let me find it. Oh, I didn't even write it. Anyway, we end with the reassessment, right? So if it's a scenario I give you in class, are you going to reassess every 5 minutes or 15 minutes?
Every 5, you say, just to be safe.
Every 5. Can't go wrong with it. And we're only ever going to give you unstable patients anyway, because in class, like I said, it does me no good to give you a sprained ankle where everything is perfectly fine except that ankle. I need to see you go through and do your primary assessment, do certain interventions and ask a whole bunch of questions. And the only way to really do that is to give you bad patients. So in class, in testing, in your boot camps, unstable patients. All right, something about it will make them unstable. So 5 minutes. If they are stable though, because in the real world, the majority of what you're going to deal with are actually stable patients. Stable doesn't mean healthy. Stable just means they're not actively dying on you anymore. So even if it's a bad call, if you've stopped the progression and you have very securely, they're okay, or at least they're not getting any worse, then they're stable and you can do 15 minutes, but you're really only going to see that in the real world. You're not going to see that in class. So keep that in mind. I don't want you guys to be like, oh, I'm going to do this every 15 minutes. I'm like, really? Because your guy is like one step away from CPR. So just be aware of that. All right. I know it's not quite time for your break yet, but we've already covered everything that I had on the whiteboard. We've done the review. So take a 10-minute, actually, I'll give you an extended break. Come back 10 after. All right. That's 14 minutes. So 10 after 7, we'll pick back up if Chris isn't already here. And we'll continue on. I'm going to find where we're at in the slides and move on from there. See y'all in a few. All right. No, it says 7:10, it's 7:09 and some change. So we're going to get back on it. Actually, let me turn off do not disturb in case Chris finally reaches out. All right, so we're gonna get back at it. We're just gonna kind of go over some different things that you may run into that can complicate your assessment. And then we're gonna kind of finish up with a little bit of a rundown. We're gonna talk about the primary, or not the primary, I'm sorry. We're gonna talk about your head to toe. From right now, it's an awareness. Again, I just want you guys to be aware of what that entails. We'll talk about how you assess the abdomen, the poke and press, and how we divide it into the quadrants and all that stuff. You're not going to be masters of it. It's kind of like chapter 6. In that we will continue to kick this can, beat that horse, however you want to say it. We're going to just, by the time you get to the end of these lectures, you will be a master of this. So I don't, if it's information overload tonight, I'm sorry. This chapter is one of the last big, broad, here's a whole bunch of crap chapters to kind of give you an overview. And then from here, we start breaking things apart and looking very detailed into each one. So you'll keep coming back to this. You'll keep coming back to chapter 6. Eventually, when we get to module 5, you're going to come back to chapter 7, whatever, or not, whatever your lifespan and development chapter was, because that's what we're dealing with at that particular moment. The anatomy and the lifespan and development, this chapter, these are all very broad. None of us expect you to have a mastery or even really a competency, not completely in this chapter at this point. So I know it sucks, but we'll take breaks. If you need to get up in the middle of this, y'all don't have to wait for me to give a break if you got to go somewhere. But anyway, we're going to press on because I don't want to tie up too much time, and I want to spend some time actually having you guys engage with me, and let's go through some of these assessments. I'll give you just some basic information just to kind of get you used to saying, well, we're going to start with BSIC and safety, on from there. All right, so let's talk about some things that can kind of make your assessment not quite as easy as what we're talking about right now, which is pretty much 99% of the calls you're going to get. Something will make you start to question your life decisions. But first thing, alcohol and drugs. This has gotten a little bit better for us in recent years. Alcohol and drugs and diabetes, they mirror each other a little bit. So if you're not the first on scene, if the law enforcement happens to be the first ones on scene, a lot of times, at least in the past, like I said, they've got better. We've gotten better, all that. They know to call us to make sure it's not diabetes. Or at least most of them have learned that. But we live in the real world. Not everybody is always having a medical emergency. Sometimes they partake a little too hard with the things that are out there. I mean, I myself, I love to have drinks and stuff like that as much as anybody else. Sometimes it just gets overdone. You're going to find patients that are like that. Patients that either drink way too much in a short amount of time and you have to deal with that, or patients that have just drank for way too long and they've developed some major chronic conditions because of all the alcohol they've had. You get cirrhosis of the liver, which makes certain things work a little differently. You as a basic don't necessarily always have to worry too much about cirrhosis, but because of what the liver does, as far as like breaking things down and filtering them out and things, when you deal with the paramedics and the medications they give, the doctors for sure, and the medications that they give, alcoholism really plays a part because those medications, the dosages that they're used to giving and stuff like that, they're designed for a functioning liver. If you have hepatitis, if you have, in this case with the slide, if you have cirrhosis of the liver, that changes some of your patient's physiology and it can make things a little bit more difficult. So this is something to note. Now, I will say this, do not put into your report that the patient was drunk. Do not put in your report that you think the patient was drunk, because if that report goes to a courtroom, one of the first questions they're going to ask you is, how did you know that your patient was drunk, right? You could find a guy hanging out outside the bar altered mental status with a bunch of empty bottles of Maker's Mark sitting around them. And can you really tell that that patient is drunk? I mean, honestly, subjectively speaking, or I'm sorry, objectively speaking, can you really determine based on your scene size up whether or not that person actually, how do you know those bottles were theirs or that they weren't already empty? We don't, at least especially not in the sense of what would stand up in court. And you really don't want to do anything that would discredit your report, because the minute they find that hole, they're going to start to nitpick and really it just takes away whatever credibility you have for the rest of your report. And if it ever came down to you defending why you did something, if they find that hole, all your other defenses get thrown out. So when you're dealing with alcohol and drugs, you can put that you smelled alcohol. You can put things that you can actually observe, but you can't go so far as to say that they were drunk or that they drank it, right? So you found the patient, altered level of consciousness with X amount of bottles around them. You can by all means paint the picture. Just don't make anything that's an assumption. Just understand too, when you're dealing with patients that are under the influence of alcohol and drugs, people sometimes just aren't themselves, right? I mean, think about it. If you've ever had too much to drink, you send out texts you really regret the next day. If you're just not there, you really can't always trust what they're telling you. They're usually, nobody's going to admit to you that they're taking drugs, right? So you get a patient, you wake them up with Narcan, which only works on certain things, and they're going to tell you, just absolutely nope, I don't do it. I don't do opioids. I'm not a drug user. But you know, also keep in mind too that they may not have done it recreationally. You get some elderly patients who might be prescribed fentanyl. They take their fentanyl, they start hurting 4 hours later, they forget that they took their fentanyl, or they think they can take some more because they need to get rid of their pain. So they take some more. And then they've overdone it. Now they're having an opioid crisis, and it was through no real fault of their own. It wasn't like they sat there and decided they were just going to hit all their fentanyl. They did it because they either lost track of time or were still in pain. They should have called their doctor, but they didn't, because you'll learn elderly don't like to chance things that are going to take away their independence. So they're less likely to call 911. They're less likely to call the doctor. They're just going to take more meds to make it more manageable. And then you're going to wind up responding to an unconscious elderly patient that Narcan woke up. So it doesn't necessarily mean that they did it because they're a drug user. And it's the same thing, especially with the amount of disabled and injured vets that we have out there. You're going to start seeing that in younger populations too. So just make sure you don't pigeonhole yourself. You may not be able to trust the answers they give you. Document it as patient stated if you're not sure. All right. And then make sure you don't judge. That's one of the big things. Physical abuse or violence. The biggest issues with this is that these are never fun. All right. You know, we're going to talk more about these in future chapters and everything. But when you're dealing with physical abuse or violence, some things we're mandatory reporters on. So you're going to see some things out there that stick with you. Follow your local protocols. There's going to be times where you may not be able to be alone with your patient because of what's happened. And then based on your gender, you may not be able to expect to ask certain questions or have the ability to get your full assessment done because of, in light of everything that's been going on. You're going to have law enforcement on scene and they're trying to get information. You're on scene. A lot of it can be information overload, sensory overload on your patient. That can really suck. They can really make it suck for you. Imagine how bad it is for the actual patient. All right. So follow your local protocols. That is there because everywhere is different. And I'm grateful that that's there because you guys come from a wide range of locations. Almost every single one of you is going to have a different procedure on how to handle that. Don't accuse, obviously. If you need to involve law enforcement, you do so. Let me ask you this. Let's say that you arrived on scene to a child that you think was abused. And you get ready to take said child to the ER. And the parent is vehemently saying, I need to ride in the ambulance with the kid. Do you let them or do you say no? There is a right or wrong answer. There is a right or wrong answer, but I'm going to say at the moment, I'm going to say there's not, because I want to hear you guys, your thoughts on it. So would you, I'm sorry, I overspoke somebody. Would you let them in the truck to ride if you suspected child abuse, or would you say, no, I'm not going to allow you to ride with the kid?
Advise police and let them ride.
Good. Why wouldn't you say no?
Because they're still their parent.
Right. And again, just like what we talked about with the drunk slide, we don't know, right? They could very well have been abused. How do we know it was by that parent? How do we know it was by either? Could have been an uncle, could have been a kid at school. Kid used to be accident prone. My son, every 10 minutes I hear him going, ow, and starting to cry. He hits everything. I don't understand how, I'll be honest with you, I don't understand how we had something said about us. He's got bruises all over the place, runs into things. You may have different cultures will do things that may appear to be abuse, but they're really not. For example, some Asian cultures, I think it's Chinese, but I don't know exactly which. When somebody gets sick, one of the first things they try to do, they call it coining. They'll take like a hot bar or something like that, and they'll rake it down the back of the sick person. And they usually leave red marks, whelps, all this stuff. It looks gnarly. Like if you saw it and you didn't know what it was, you'd think that they got the hell beat out of them, but they didn't. All right, that was just that culture's. I'm not really gonna, it's not so much of a religion thing, but it's just that's what they think or what they expect to help heal certain issues. And they'll probably, a lot of times they'll do that before they call 911, because again, 911 is the emergency. We're not the, oh, you have the sniffles. At least most people see it and understand that. They call us when there's nothing else. So the coining has already been done. The whelps and the bruises and the red marks, they've probably already shown up by the time you get there. So just make sure that you're understanding of that. Take everything into context. If it doesn't look like, if it doesn't fit that they might be abused, they may not have been. But at the same time, don't refuse to report it. If it looks like it might have been, mention it. Tell somebody at the ER, whatever your local protocols say. You may have to tell law enforcement, you may have to tell the doc when you get there. It just depends. But let them know. You're like, look, this is what I saw, and I'm not sure. It's a Chinese family, so I mean, it may be coining, or it looks like child abuse. But it looks like the kid. They said the kid fell down the stairs, but it was a one-story house. That sort of thing. All right. Sexual history. We're going to get into some scenarios in class where you're talking to females of childbearing age about whether or not, you're figuring out why their stomach hurts. The easiest way to look at this is just to say that anybody that could have kids is pregnant until proven otherwise, because we really almost can't trust what they're going to tell us, especially if you're asking a 15-year-old girl or a 16-year-old girl while her parents are right there. Guarantee you, I'll put money on it, that answer is going to be absolutely not. No, why would I not? When they may well have been. And if they're having pregnancy complications like an ectopic pregnancy, that's life-threatening. So you want to take that into account. If they tell you no, fine. Don't accuse them of being a liar or anything like that. But just understand that they could be not being honest with you. So what can you do? If you have a patient that's, we'll say 17 years old, possibly could be pregnant based on just being a 17-year-old female, if nothing else, and she's complaining of lower right abdominal pain. So be a couple things you'll learn about later on, but as far as the questioning is concerned, if you wanted to get honest answers out of her, or at least the closest to it that you might be able to, what are some things you can do to try to get your patient to open up and be honest with you? Ask it privately. Good. Yeah, that's a big one. So where exactly would a private place be? What's a good private place to ask that question?
In the back of the ambulance.
Yes, in the back of the ambulance. Get them in the truck, right? You can save that question. And not just for that. There's going to be other times where let's say you showed up to a guy that was just laying on the floor unconscious family's freaking out, and you're like, there's nothing wrong with this guy. I don't understand it. His vitals are fine. I even like did the arm drop test or whatever, and he moved his arm to the side, like, okay. Don't call him out in the middle of the room. Don't call out the girl is possibly being pregnant in the middle of the room. Give them the truck by themselves. You'd be like, hey man, there's nobody around now. If you want to open your eyes, or something like that, and you just test it. If he doesn't do anything, then great, whatever, fine, treat him accordingly. But if you think he's faking, they may be doing that because he's tired of dealing with somebody in the house. Give me just a second. I will be right. All right. So anyway,
Let's get it, dude.
is that Chris? Anyway. All right. So back at it. I don't know who that was. All right, so we should be back where we're at. I want to stuff this back in order. Yeah, ask them in privacy. All right, and even if they told you no, if they're like, no, I'm not, but you can't rule it out, then don't rule it out. It really doesn't change your treatment. It just lets you, you're thinking about that, like, hey, patient could be pregnant. That's all there is to it. There's some extra questions you can ask. When's the last time they had their menstrual cycle? Anything of that sort. Just keep in mind too, when you're dealing with kids, not kids, teenagers, adolescents, there's no real regularity. That whole, it's on this day every month or whatever, that comes as they get older. So they might be late at 15, 16 years old. That might be, there's nothing to it. But again, document it. I don't know, if you're a couple days late, that's one thing. If you're 4 weeks late, that's a little different. And then if you need to worry about it for whatever reason, ask about the possibility of any STDs. That's as much for your safety as it is for theirs. There's really not anything that you're going to do in EMS that an STD presence would change. But it may be good to put it in your report. All right, silence you're going to see mostly in your geriatrics. Either geriatrics or small kids. If you're a stranger danger to the kid you're trying to work on, and he's not, he or she is just not having it, they're hugging up on mom and burying their face, and they're not answering you, you may only be able to get that physical assessment. Sample may not happen, or you can get sample from the parent. If they're elderly, sometimes you run into the same issue. Elderly patients that have been silent to me, or at least in my experience, I've noticed is because either I or somebody else has, for lack of a better word, we'll say offended. We didn't call them sir or ma'am, or we did call Jesus. People in the Northeast, they don't like that. You call them sir or ma'am, they see that as an insult sometimes, like holding the door open for somebody. Sometimes you'll get that response of, I can do it myself. Like, why are you doing it? Are you patronizing me? Or what? Like, hey, I'm from Mississippi. I grew up getting sir and ma'am beat into me as a kid. So no, I'm not patronizing you. But sometimes you'll see that. People see what is considered to be good manners or offensive can change depending on the region that you're in. Lock up. There we go. All right. Overly talkative. I haven't seen this one in like an actual patient. Usually if they're well, no, I take that back. There was a hyperglycemic patient that we dealt with once that was his sugar was so high that it had brought his blood pressure over 200, and you could see it. His eyes were kind of bulging out of his head. It was weird. But I know the slide says ingestion cocaine, crack, any kind of meth, things that really hype people up. They're going to be jittery and talking a lot. Sometimes that's just their personality. One of the first classes we taught is ARES. We used our instructors to teach for the college before we got the program off the ground all the way. And one of the students in the class would not be quiet. And it had absolutely nothing to do with what we were teaching. She'd be like, well, that reminds me of the time that blah, 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 blah happened. And I'm just like, what is this? That's absolutely nothing to do with what we're talking about. She just couldn't sit there. I had to actually let her sit close to the door so that she could get up and leave the room almost every 2 minutes and then come back in, just kind of resetting, because she couldn't sit there. It was in her personality. Multiple symptoms. Sometimes again, I told you, like in class, we're not going to give you the guy that had the heart attack driving down the road and then hit the tree and give you a medical trauma or something of that sort. It's going to be one or the other. But in the real world, you're going to see that. You're going to see patients that were walking through the parking lot and for whatever reason, they had a diabetic emergency, and now they're running through the parking lot and they get hit by a car because they had an altered level of consciousness. Or insert medical and trauma here, or even two medicals. You might have a heart patient and a stroke or something of that sort. So now you're trying to sort out what you're dealing with, and the questions, you might wind up asking questions for one thing and they're not making sense because they apply to the other issue. You'll see that a lot with elderly when those issues kind of start to stack up. But usually what you'll do is, as long as you're following your assessment and you treat A before B, and you make sure that you're hitting those primary assessment things, you may not be able to solve anything. All you may do is just give them O2, get a whole bunch of weird question answers that don't make any sense, and get them to the hospital. And you just stick to the primary assessment and keep them stable. And that's the best you can do. So you just prioritize it based on your assessment and then move on from there. Anxiety sucks. But I will say this, let me ask you this, what primary assessment issue starts with anxiety as a sign? Anxiety is a very early sign. Most people miss it, and then it becomes a bigger problem later on. But if you recognize anxiety as being one of the first signs of it, you catch it before it becomes an issue, and you get them to the hospital in a much better condition.
Depression?
No, a good one. Actually, yeah, it's a good one, but no, not depression. Think of it to pick up in your primary assessment. Okay, shock's one. Shock's a good one.
Stroke?
Kind of. Yeah, stroke could be, but stroke would be more of a portion of the issue. I want you to think just basic ABC, particularly in breathing.
Respiratory distress.
There you go. Yeah. So we have, like, it's right here on the slide. It's the third one down, shortness of breath. When a patient starts to become hypoxic, right? We're always thinking of those signs of like, oh, they're going to have cyanosis, right? Blue lips and altered mental status. Well, anxiety is an altered mental status. One of the first things that happens to a person when they start to lose their O2 sat is they get anxious. The body, think of it like this: if you couldn't catch your breath, you were trying to, but I'm not getting enough air doing my normal breathing. What are you going to do? Your body's going to start to pick up the pace of your breathing. And so, well, a lot of times when you respond to those trouble breathing calls, those shortness of breath calls and stuff like that, COPD patients that are having a hard time breathing, before you see the blue lips, because that's kind of a late sign, before you start to see those physiologic issues, you're going to see anxiety. They're going to be propped up in that tripod position, acting like they just ran the race. They're freaking out, and you walk in the door and they're like they're digging in your bag because they know you've got the O2 and they know what it is, especially COPD patients, because it's not usually not their first rodeo. Yeah, they're high anxiety. So if you're working on a patient and as you're doing your assessment, you notice that their anxiety is climbing up. A lot of times that is the beginning stages of hypoxia. And if you can catch it and give them some oxygen, you can actually stave off a lot of stuff. You stopped it right there. Anger and hostility. Unless it's I don't know how to say this, unless it's like a behavioral emergency where you really, even they can't control it. A lot of times the way you present yourself will help a lot with this. You just remind them like, hey, sir, I'm only here to help. You don't want me to take a blood pressure? That's fine. Hey, we can wait. Sorry, whatever. What about, can I do this? Ask, and then you can ask them. It's like, you stay calm and reassuring. Ask their permission before you do things. They may want you to help, but something in your assessment, they may have a phobia of it. Like, for example, I mean, even myself, ain't none of y'all giving me a catheter, not in EMS, not in the hospital. If I'm getting one of those, I need to be knocked out before you do it. And I need to be asleep when it comes out. I cannot do it. I would rather take a dose of lead in the form of a bullet than take a Foley. That's just me. I mean, if I can find a way to get that into my DNR, I will. But anyway, as long as you can talk them down, like I said, if it's a behavioral thing, nobody may have any control over that. But if it's just, they're just anxious, they're just upset. They may have been angry, angry driving, hit a tree. Now their stress level went from here to here. If you can calm them down, as long as the scene is safe, that's all right. You can get around. If you just couldn't get your BP, just put that in a note. Hey, patient refused blood pressure or something of that sort. If you can't get the scene to calm down, back away. All right, you can call in law enforcement, or you just let them go if it's something that they're able to sign a refusal for. Again, you don't have to force somebody to the hospital if they don't want to go, and then all those check marks are there with like they're in their right mind, they're A&O, whatever, but fine. All right. If you can't secure the scene, you can always call for law enforcement. Intoxication, we're not going to talk about because we talked about it with drugs and alcohol. Crying is a manic episode. Whether it's anger or fear, depression, or whatever, that's crying is a result of something of that sort. So it kind of goes back to that same thing of, can you calm the scene down? A lot of times crying is not a threat. Somebody's crying, but it can progress if depending on why they're crying. Same thing, just be calm, collected. Try to bring that red line down a little bit. The biggest issue with depression is it really nobody understands it except the person that's going through it. There's so many different forms of it out there that we just call it a blanket word, like, oh, you're depressed. Please don't ever say that to somebody. You're just depressed. But anyway, there's so many different things, like for one patient, depression may mean stress eating ice cream by the gallon and just sitting there watching Hallmark movies and crying it out, and then they're perfectly fine, or they'll come out of it or whatever. Other people's depression makes them to where they feel like they're mentally in quicksand up to their neck, and so they can't get through the day because they feel like it's an act of Congress to move or get out of bed or something of that sort. So, going by the side, be a good listener. Just understand that the way, even especially like, for example, a lot of us have depression. I have it. Some of y'all may have it. What registers as depression for me may not be anything like what my patient is telling me their depression is like. So just listen, even if you don't understand it, that's okay. Let them get it off their chest and then get them to the hospital if they need to go to the hospital. The biggest issue with depression is suicide risk when it gets bad enough. So if you're talking to them and you start to get that idea that they may be a threat to themselves, don't leave them alone. take them to the hospital. A psych reason, that's a psych reason that's worth going to get checked out. Just better safe than sorry. All right, confusing behavior or history is kind of getting into those altered mental statuses. So if anybody has ever experienced a diabetic patient, somebody with hypoglycemia, I know some of y'all are EMRs, some of you may have family who suffers from it. When certain things start to mess up metabolically, our brain starts to mess up, and then we have that altered mental status. Your brain's a big baby. It's the first thing to complain when something goes wrong. And there's really only a couple of things that it needs to operate, right? It's sugar and oxygen. So if any of those start to go away, if it get either too little, too much sugar or too little oxygen, the brain starts to complain. And that will do things, right? So like too little oxygen, brain's like, hey, I'm not getting enough oxygen. First of all, what's the first thing that's going to happen? What's as far as your vitals are concerned, what's going to climb first? Think about your vitals, the ones we talked about. So your blood pressure, is that going to spike real fast if you run low on oxygen? Your pulse, your respirations, or your O2?
Probably your respiratory rate, because your body's trying to bring in oxygen.
Exactly. And your respiratory drive does a whole lot of things. It's considered a buffer system for a bunch of different reasons medically. So it controls your end tidal CO2. What your acid base balance is, which is a lot of that's out of scope, but just understand that your body is going to rely on your respiratory drive as a quick fix for a whole bunch of things. So if your O2 gets low, respirations go up. Respirations climbing is going to drag your heart rate with it because they move together. So if your respirations climb, your pulse is going to climb, but your respirations go first. If your CO2 gets too high, your respirations are going to go up because your body's trying to blow it off. If it gets too low, your respirations are going to slow down so that your body has time to build it up. It's all about that balance. Think about it with sugar, same thing. If your brain is not getting enough sugar because it's too low in the blood, your body's going to lower the amount of insulin so that you have and release glucagon that turns into sugar. So your brain controls everything, right? I mean, if you think about it, all we are is just vehicles for our brains. Everything, all that does is make the brain happy. And when the brain's not happy, it starts making a fit. So that's our altered mental status. You'll forget where you are. You may be the nicest person anybody's ever met, but if you start having that altered mental status, you could be combative, you could be confused. You just have to make sure that you stay safe, right? And just understand it again, just like when we talked about with the alcohol, you may not be able to trust the answers that you're getting if you even get those answers. If they get so far off in their altered mental status that they can't talk to you anymore, you may just not get anything. And then we have dementia, delirium, Alzheimer's disease as patients get older. These can also be barriers. So if you need to, you can talk to the family. A lot of times spouses, kids, parents, depending, they may have the answers you need, even though your patient's not able to give it to you themselves. Limited cognitive abilities goes the same. If you can't get it from the patient, get it from family members. Cultural challenges. Oh, when you're talking to other medical directors, there we go. Chris is in the house. All right. So, Chris, if you want to just sit back for another 15 minutes, we'll take a break and then I can hand it off. But anytime you want to jump in ahead of that.
Still following up on paperwork, but I'm gonna listen to you.
Okay, there you go. When you're talking to each other, when you're talking to other medical practitioners in the hospital or something like that, medical language, absolutely, if you want to use it. When you're documenting in your reports, definitely be professional. You know, you use medical terminology, that's fine. But if you're talking to somebody that's 12 years old, they're not going to know what tachycardia is or something of that sort. So use your language, use the words that fit who you're talking to. Understand that some people may not want to talk to you because you're a guy and they're a girl, or you may be dealing with a certain religious, like let's say Arabic people, and even some Christians and other religious sects that are out there. If it's a sick girl in an Arabic household and you're a double male response unit, depending on how devout they are, they would probably rather see their daughter die than have you fix them, because they can't let a male touch their female child. If it's issues to do with sexual assault, same thing. The gender issue is going to rear its ugly head. So you may have to radio another unit if that's the case. You can enlist the help of healthcare providers of the same cultural background, because they're going to know what faux pas to avoid and stuff like that. You may be able to enlist the help of a family member if you're like, okay, but what about your mom? And if I give advice, will you do this? And then that way you have that barrier. Just some other things to think about. And we talked about coining with Asian families. Just because they do it doesn't mean it's assault or abuse. That's just something that they may do it. Language barriers, that's fun. So I'll tell you, I learned what a udame meant before I learned anything else in the Spanish language, because that was all that was being said to me by a van full of Mexicans that had been in a wreck in Laurel. And that was all I could get out of them was udame. I didn't know what that meant. I looked at my partner and they're like, it means help me. I'm like, oh, okay, I got you. If you know somebody that knows language, fantastic. If you don't, you can do it kind of like how you talk to a child. Just be very careful doing that. All right. Because again, you don't want to offend, but if you can just be like, I don't understand. You're like, where does it hurt? And kind of punch yourself, does it hurt here? Is it here? And that kind of thing. You can kind of bridge that gap in a very basic extent. I know that in this area, a lot of people speak Spanish. There's apps on the phone, and actually it's even easier now because of Google Translate, stuff like that. You can just speak into the phone in English and it says it to them in their language. You just set the language that you want and it goes from there. So this barrier is getting a little bit easier. The biggest issue that I can say, and you'll learn about this when we get to the stroke chapter, depending on where the problem is in the brain, this may be another English speaking person, right? So somebody you wouldn't never think you'd have to have a problem or have a barrier with. But the Broca's region of the brain is what's affected, which is on the left anterior side where my hand is. If that area of the brain is affected by either a stroke or a clot of some sort, speaking English, but the words are just not what you would expect. Like they will point at a glass of water and a football or something like that. They're trying to say a glass of water, but what's coming out, the interpretation area of the brain for language is messed up. And so you asking them questions, you may run into that issue. So just be aware of it. Hearing problems. We just talked about this, and Chris, this might have been your class. I don't remember, but oh no, it was the advanced class. Who thinks you have to shout at the elderly to make them hear you when they have hearing problems? How often is that actually the case?
It's very rare.
It is pretty rare. So when you think about hearing loss, what comes to mind? And those of us, if anybody in here is a military vet or has just spent their life on a very loud area, concerts, flight lines, that kind of thing, is it volume that you have a problem with, or is it certain frequencies?
It's frequency or tone that you're missing or unable to hear.
Exactly. A lot of times what's happening is that you start losing hearing loss from a frequency. So you can't hear above a certain note. Sometimes, actually a lot of times, and sometimes it is volume, but if you come across a patient that's having a problem hearing, don't just start screaming at them or, can you hear me? Because that'll tick them off real quick. Ask them, like, is it pitch or volume? If you lower your voice and speak in like a deeper tone, they may hear you just fine. If you're a higher pitched person, my daughter sounds like a whistle right now when she speaks. in about 10 years, I mean, if her voice doesn't lower, I'm not going to hear her at all because my hearing is already crap. And she's way up there. But I mean, this is actually pretty easy to get around. If they can't hear you, write it down. Have them write it down. Hey, real quick, pull up the NREMT website, pull up that checklist, pull up sample and let them read it. Allergies, all right, well, no, medications, they'll write it down for you, or they'll just tell you, just because they can't hear you doesn't mean they can't speak. So you may be able to hear them just fine. Visual impairments, if they can't see your uniform, your patch, that kind of thing, just make sure that you're telling them who you are and what you're doing. A good example of this is a patient who may be seemingly unconscious, right? And we try to teach this in that just because your patient's unconscious, if you're going to do work on them, don't just silently sit there and hook up a blood pressure, or if you're an advanced provider, start stabbing them with needles trying to get an IV. Because they can't respond to you doesn't mean they can't feel, or that they're not aware, or something of that sort. You may have somebody that was in a car wreck and popped just the right C-spine, the vertebrae, to where their body's shut down, but the brain is still completely active. Paramedics training, Chris, have you ever seen somebody do an RSI backwards? Hopefully not, but
Unfortunately, I've seen it twice, and it's not the best thing in the world.
no, that's got to be scary. So basically what that is, there's two drugs that a paramedic will give when he's RSI, or rapid sequence innovation. The first thing they do is they put you to sleep so that you're not aware of what's going on. Then they paralyze you so that they can put a tube down your throat to breathe for you. Burn patients with bad airways, that's one of the examples of that. If you do that backwards, now you've got a patient who is paralyzed, they're shut down physically, so you're not going to get any response out of them when you're doing your neuro checks or whatever it is you want to do. They're going to seem like they're unconscious, but their brain is very much active. They're very much awake. You hear horror stories about that from people in surgeries. Some trauma can do that. Certain medications can do that. People may accidentally do that to themselves, depending on what they've gotten a hold of. So, if they're unconscious or if they can't see you, just think out loud. Like, all right, Rob, I'm an EMT. I'm going to be getting I'm going to go ahead and start with your blood pressure while you're putting the cuff on. Like, I'm putting this blood pressure cuff on your arm. It's going to get a little tight while it inflates. Don't worry about it if you feel it. If it does start to hurt, give me a sign that it's hurting, tap it or whatever, so I know to undo it, and just going from there. Try to make up for whatever sense that they don't have. All right, we already discussed the secondary assessment, so I'm going to go through these. I'm not really going to worry about these slides. Same thing with your focused assessment. But actually, I'm going to talk about, let's, Chris, I kind of jumped off slides a bit as we went. So some of these I'm going to hit, some of them I'm not. But let's talk about you have two different kinds of assessments. You have your medical and your trauma. So one of the things that I want to talk about right now is going to be in your focused assessment. Let's talk about trauma first. So again, when you show up on a scene, what's the first part of your assessment that you're going to do? Is it your size up, your primary, or your secondary?
Any size up?
Scene size up, right, good, all right, so that's take care of number one, which is you triage your scene and take a look at your patient. So BSI, scene safety, take care of you. Number of patients and the need for triage, and then MOI, NOI if it's medical or trauma, and consider C-spine. Always consider C-spine, even if it's a stub toe. It doesn't mean you're going to put the collar on them, but just consider it. All right, then you go through your primary, so your level of consciousness, ABC or CAB, depending on what that level of consciousness is. And then you get to your secondary. So now we're worried about, here's where we really are going to kind of fork off down the road of, are we going to go the trauma route or the medical route? By the time you get to the end of your primary, you should absolutely know that, especially in class, because again, we're only going to give you one thing. It's going to be trauma or medical, and it'll only be one issue within them. If it's trauma, when you get to your secondary assessment, remember I told you you could either do your vital signs first, your history first, or your head to toe. I always recommend the head to toe. And that's what these slides are about to get into. So you can't move your patient in trauma until you know what their injuries are. You don't want to roll them and then throw a board under them if they're on a cracked hip, because what if you don't know that? What if you roll them under the cracked hip? They may not have been bleeding out before, but if you've made that injury worse, now you've given them a life threat. So we're always going to start with the head to toe assessment in trauma. And what you're doing is you're just surveying the scene. You're really not fixing anything at that particular moment. You're not going to splint any bones. You're not going to, outside of like hemorrhaging, bleeding, you're not going to, you're not going to fix any mild cuts or any minor injuries, burns. And that's not what you're worried about right now. We want to get them in the truck and go. So head to toe, all right? That's what you're doing. It's like the head, shoulders, knees, and toes. You're going to work through and see what you see, and you're just going to note it as you go down. You're going to go from head to toe. Once you've gotten that, and you get ready to roll them, put them on you can check the posterior, lay them on the board, get them in the truck. Once you're in the truck, now you're back to that point of being able to do whatever order you want to do. If you want to get vitals after that, fantastic. If you want to get your history, if they're awake to give it to you, fantastic. That's where now you can kind of make your decision. There's another mnemonic that I want to give you. I'm not going to bother the whiteboard because we got about 5 minutes left. And again, this is just an exposure chapter. So you're going to, when we get to module 4, you're really going to start to hammer in on this. But it's DCAT BTLS. D is deformities. So if I have a bend here in my elbow like I should, but I also have a bend here in the middle of my forearm because I broke it, that's a deformity. If I have this giant goose egg on my forehead, that's a deformity. So you're looking for anything that just doesn't look right, like they're trying to smuggle a golf ball under their skin, that kind of thing. Contusions, who can tell me what a contusion is? It's a fancy
Bruising.
word for a very common issue. Bruising, there you go. So why don't we just call it a bruise? Because that would make too much sense. Now, so a contusion is a bruise, but a contusion is typically going to be a bad, like a particularly bad bruise. If I've got a little bitty bruise right here, I'm not too concerned about that. If I've got this gnarly seatbelt bruise that goes all the way across, that's a problem, right? That's usually what we're referring to when we talk about contusions, because what makes the bruise is blood. That's why it hurts when you press on it. Blood's an irritant. If blood is anywhere outside of a vessel, it's going to hurt. So bruises hurt. And all the blood you're seeing is outside of the vessels when you're looking at a bruise. So a little bitty bruise, no big deal, unless it's, I don't know, I can't even location where that would be a problem. But if my entire stomach is bruised, that's a problem. That's a lot of blood, right? So that's kind of what you're concerned about there. All right. A is abrasions. Thank you, Bailey. You put them up there so everybody can kind of see it. So that's your carpet, carpet burns, whatever. Again, we're worried about the major things. So think more on the lines of a motorcycle accident with road rash. That's the kind of abrasions we're worried about. P is punctures, penetrating injuries, so gunshot wounds, knife wounds, rebar, tree trunks, whatever might get thrown through somebody. That's going to be what that is. B is burns, self-explanatory. We're going to have a good chapter on that later on. T is tenderness. L is lacerations, and S is swelling. A laceration is just a cut. That could be something minor. It could be something that runs the entire length of your forearm or across your stomach or anything. So again, I'm worried about the emergency ones. I'm not worried about the paper cuts. All right, so everywhere you check when you're doing your head to toe, that's what you're going to be checking. We're going to teach you some other things as you go to kind of build on that. But before I let you go on break and before we start talking about head to toe assessments and how you're going to check your abdomen, I want you to, in the sense of, you have to explain to your evaluator what you're looking for, because we want to see in front of us that you know what you're doing. So if you're on a scene, I don't want you to sit there and on your actual patient and be like, all right, deformities, contusions, abrasions, looking at your partner, and your patient's looking at you like, what is going on? In the class, in your assessments, I do want you to do that. So when you're thinking about, or when you go to do your assessments, when you get to the head to toe, I want you to actually tell your evaluator, tell your instructor, I'm going to start my head to toe and I am looking far, and then you rattle them off. And by the time you get to this, you'll be able to. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations. I'm looking for that. So that as you move through, you can just check. And if there's something in that your evaluator or your instructor wants you to know that is there, they'll just tell you. That way you don't have to be like, I'm checking the head for decap BTLS. I'm checking the eyes for decap BTLS. It'll take you all day to get through it doing that. So just, say what it means and then move through. And then depending on what you're looking at, if you have penetrating injuries, that kind of thing, if you're worried about sucking chest wounds, which we'll talk about later, you can always say that on top of it, but you don't have to keep repeating the decap BTLS every single time. We will pause there. So take a 10-minute, and I'm going to do a warm handoff with Chris so that we can, well, wait a minute. All right, I'll hand them off later. Go ahead and take a 10-minute break though, because it's just been an hour. And we will continue. See you guys soon.
Hey, what's up, folks? Can y'all tell me what y'all are looking at right now so I can make sure I'm on the right screen?
Reassessment 404.
That would, yeah, so you see the big one, right?
Yeah.
Okay, good. All right,
Hey, Chris.
just gonna let y'all continue your break. I was just making sure I was getting straight, so I'll see y'all back in just a minute.
Wally.
Sorry, I'm here. Go ahead.
Hey, I told Robert earlier at the beginning of the class, here in a few minutes, I'm going to have to jump off and check in for a sleep study. So I will not
Yeah,
be.
bro, you take care of you. That's important.
Okay, so how will I get the?
Send me a Discord message and I'll let you know.
Okay, I'll do that. I appreciate it. I'll be jumping off here in about 5 or 10 minutes.
Yes, sir.
All right.
Hey, I don't know how long it's been. I really didn't even look at the clock. If it's been time or not, it doesn't, I can't really tell you. So has it been around 10 minutes?
Yes.
Okay. Also, I noticed that there were some things that were, the sound was a little rough. So if y'all start to hear that I'm a little crackly or something, please let me know. I'm kind of watching the chat down there to make sure that nothing is missed. And if I get a little crackly, I don't know. It keeps telling me my internet's in and out, but I've got great service out here. So let's talk about respiratory. I caught up with Rob. So the biggest thing we want to know about respiratory, when we go to assess our respiratory system, is things are going in and out the two passages that it's supposed to. We want it to go in the nose or in the mouth and out those two. If you start to see signs of airway obstruction, the biggest thing we want to do is make sure that it's not impeding the airway, or if it's not intruding the airway. And what I mean is, then, like, something has punctured the airway, we can only remove it if it's in one place. It's in the cheeks, potentially blocking like an oral pharyngeal, an ET tube. But if it's anything other type of impairments, we can't move that. We do want to look for symmetry. So when we talk about symmetry, is y'all have to understand, I'm from Mississippi, so not everything's equal round. Well, we all round, but it's equal and it's up and down and in around, and it's supposed to be normal flow of oxygen. So we want to make sure that we measure, are the respirations adequate? Do they have adequate respirations for their breathing, for their age, for their size? Do they have everything that's supposed to be there? Am I worried about tidal volume? No, I'm not. I'm really not worried about tidal volume right now. I just want to know, are they moving in an air and is it adequate? Because when we dive further into this, I'm going to get more about your OPAs, your NPAs, your BVMs, and yes, I'm using abbreviations for obvious reasons, but I want y'all to focus on your assessments. What am I looking for? If you start to see increased work of breathing, like they just look like they're struggling to breathe. When you look at them and you're like, oh, he look like ass. That gives you a sign. You make up, automatically what I say. When y'all say that, you're like, oh, he's just being honest. Y'all, I'm serious. That is exactly what they look like. If you don't do something, guess what's gonna happen? They're gonna die. And you can't just sit there and watch them. You got to do something. So that's a general impression. So if they don't have the right respiratory rate, rhythm, and quality of breathing, we got to fix that. Their depth is also massive important too, because if this just, that's not adequate ventilation. That is not breathing like they should at a normal rhythm and rate. Yep. I mean, y'all pick up what I'm saying there? Y'all know what our normal respiratory rates are. Is that right? Y'all follow?
Yes.
Maybe, somewhat. Yes. All right. I don't know where my mark. I moved some stuff on my screen and I can't find different buttons now. All right, let's do this one. All right. So we know what our respiratory rates should be for the age of every group, like we went over the other night. If you're, and depending on what group you're in, I need to know, is it 12 to 20? Well, if we're talking about adults, yeah, that's going to be 12 to 20. Kids, what they going to breathe? Does anybody remember what the respiratory range is for kids? Everybody flip back in your notes real quick. Everybody's like, oh, I don't know. Okay, so we know that the kids are going to breathe faster. When y'all are searching your notes, I'm going to keep talking. We know that they're going to breathe faster than we are. What I want you to do is simple. Look on your screen. See what it says right there? Count the number of breaths in 30 seconds and multiply it by 2. Well, I mean, I hope we can add on the go. I mean, I know I went to public school and I only have 10 fingers, but I can do, some rough math. So if I count 60 respirations, that's 120. right? So we know that. So you're like, oh, well, that's kind of fast. Something's wrong. They shouldn't be that fast. Well, that's why we're teaching you in the respiratory section of how to fix it. What am I gonna do? When you're assessing breathing, you want to look for rate, rhythm, quality, breathing, and depth. So what do I want to know about their depth? Is it adequate depth for respiration? Because like I said, if you just have those shallow, short breaths, bruh, that ain't doing nothing at all. You teasing. You know, I'm a big boy and I like to breathe, so I want my deep breaths. I want adequate respirations, inhale and exhale. If people are like, I can't breathe with you doing that. Yeah, you can. Just shut up for a second, quit talking, take a deep breath. Y'all know what I'm talking about. Y'all have all seen these people. They're like, I can't breathe. Quit hollering. I can hear you. Definitely, you ain't having trouble talk. So know that. What it tells you right there, it says how you know if they're regular. So the time from one peak of rise to the fairly is consistent. So if you say, okay, that takes about 3 seconds, and they're averagely about the same. Rebecca says, how old is the child? Let's say 4. Oh no, I'm just pulling numbers out. So if we're gonna say they're 4, I want to know what the respiratory rate is supposed to be. 2025. Look at you. You found your notes. All right. What is that? Quality is normal breathing is silent. That is correct. But you know, people they're like, well, first off, quit mouth breathing. I need to talk to you. What's up? If they make average noise when they breathe, you hear like this whistle. There's an airway impediment. Y'all know what I'm talking about. I'm just being honest. I'm sorry. So if you have somebody that has an upper respiratory infection or they're COPD or they fall into that range, they're going to automatically and always struggle to breathe. Got me? So when you add airway problems or breathing problems to begin with, it's just gonna make it worse. So look at COVID. COVID, if you're a COPD patient and you get it, what's gonna happen? Your respiratory drive is gonna potentially be wiped out. That's where all of our people get put on the ventilators. Whew, lost that word for a second. So they get put on the ventilators. They get put on, you know, some people that live on CPAP. They may just be on CPAP for a while. BiPAP, you got all these different types. When you put them on a respiratory, that COVID has just killed that drive. So when we assess the depth of breathing, what is the amount of air the patient exchanges depending on the rate and tidal volume? Again, I'm not really worried about the tidal volume. I know I taught it to you, and it's potentially going to be asked maybe at one time on the NREMT, how you get tidal volume. So please know that, but I don't expect y'all to show up to our boot camps and be like, and I'm gonna look at you and be like, what's the tidal volume? I don't care. Is it adequate respirations? Is it adequate depth of rate? Is it sustainable to life? If he's breathing too rapid, no, it's not sustainable to life. So let's do something about that. And that's what I want you to fix when you're doing these skills in front of me. Fix it. Don't just sit there and look at it. I don't expect you not to do that right now, but in a couple months, I'm gonna be like, yo, bro, what you gonna do for that? And we're gonna make sure that. So when you start to osculate breath sounds, that's important because you need to know if they have wheezing. Do they have like seals when they sound like a seal? Is it a stridor? It is very hard for me to tell you what these breath sounds sound like, but Rob mentioned a very cool tool that you have at your fingertips that y'all carry a computer in your pocket. I highly recommend YouTubing breath sounds on what they sound like. Now we will go over on the next slide, and let me just show you right here, on where to place your stethoscope for your breath sounds. You need to know, and obviously we've all been to the doctor where they listen to you breathe and all that, and you're like, I'm trying to breathe normal, Okay, so these are where you want to listen to the upper lobes, the tops of both front and back, and then the lobes of the bottom lobes. And you want to listen to the front and back of both places. And the reason why that is because you can have different sounds in different places, and that's what we want to check. Or are they clear? Is the breath sounds clear and adequate? Or do I hear like it sounds like there's something wet and it's bubbly? Well, that's really bad. Okay. If it's a bubbly sound, that could be hemopneumo or hemothorax. Hemopneumo could be air or blood inside the lung, and that's neither one of those are going to be good in the long term. So we talk about the respiratory system. What am I listening for? And I just told y'all. So here might be a key word. You want to live for normal breath sounds, snoring breath sounds, wheezing, crackles, bronchi, or stridor. Those are some of the things that I highly encourage y'all to YouTube those sounds and just listen to them. And now, when you auscultate somebody, and I'm gonna tell you, if you have a stethoscope and you have the time, pick on your friends and just come on and be like, hey, bro, sit still. Let me listen to you. We all got that one friend that we're like, man, I just wish they quit smoking. Listen to them, because then you will hear the difference between a clean lung sound versus, I call them the smoker sound. Everybody knows you got that same friend got the smoker's cough, and you're like, oh, you're not sick. That's just smoker's cough. It's right. There's probably about 30 of them out here on this platform that's that way right now. So that being stated is listen to them. If you get a stethoscope, have one or one handy, just listen to people. Be like, hey man, look, I'm at school. I was told I got to listen to 10 lungs. They're gonna be like, oh, well, you're already putting your stethoscope on me. Cool, not a problem. Rock on. All right. So the cardiovascular system. This is it's so big. It's hard to dive into this because I know this is coming in later chapters. But again, you need to know. So when you go to palpate this, you're palpating the chest. You're doing a decap BTLS over the entire chest. And if I'm not mistaken, then somebody, say Bailey typed in there what decap BTLS stood for. And again, these mnemonics are going to be your bestest friends. So I would learn and write them down multiple times. decap BTLS, sample, OPQRST, all these abbreviations, because you're going to need to know them. So we're going to decap BTLS the entire chest, and we're going to listen for breath sounds. Now, I can't listen to your breath sounds sitting on the side of the road while it's raining and there's 18-wheelers moving up and down the interstate. No, but the best that if and when I can in a timely manner, I need to auscultate your breath sounds. That was most likely in the back of the truck, but what you're going to hear in the back of the truck is the diesel motor. So take note into that too. You can also listen to your heart tones. Is it like doom, 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 or is it like doom, 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 doom? So there's different tones that are out there that can tell you if there's damage or what type of rate that they're in. When it talks about pay attention to rate, quality, and rhythm. Y'all are in EMT basic, so let's make sure that y'all come back for the advanced and the paramedic sessions that we have, and we will teach you all day long about the rhythms because they are confusing. I still to this day, 20 years later, look at rhythms on a computer and quiz myself. If you don't use it, you lose it. So what you need to know in the first couple of minutes is your vital signs, and that's going to include pulse, respiratory rate, blood pressure. Now you can use the old-fashioned blood pressure with the manual cup and all that other stuff. That's cool and handy. But if you can't hear, slap that blood pressure cup on with that monitor and let it do its thing while you working off something else. Okay, I can handle that. Let's go. But if you don't have a monitor at your ability where you are just can have it, maybe you're at a service that doesn't have those on basic trucks, or it's just you're at a volunteer service and they don't have a life pack 10 or 12 or 15. Sorry, 10s are no longer around. So you need to know that quick, because that is your baseline vitals. That's your starting point. At this point, this is what I had my very first blood pressure. That's assessing your cardiovascular system, because then you know what the rate is, and you know the blood pressure. Has their blood pressure gotten any better since I've dealt with them? Well, I don't know. I didn't check their blood pressure in the right amount of time. But that's your fault, not mine. That's your patient. And trust me, when we go over these skills and going through boot camps, and if I'm able to attend one that you guys are at, I am all about education, instead of, like criticizing or why didn't you do this? Look, let me show you. Let's do this. I'm really like hands-on. Teaching this type of class was very hard for me because I was over here flailing my hands in the air and talking on my hands and expressions, and I was like, oh, they can't see me. My bad. I just talked to myself in this room. So y'all understand when we get our hands-on sessions. All right, consider your findings when assessing the skin. How is the skin? What is it? Pale? Is it, is it multi? Is it just warm and dry? Is it, what condition did you find it in? Distal pulses, those are important because we need to know what the right and left are. You can have a higher pulse pressure on the right versus the left, and that could be signs of trauma. You want to listen for abnormal heart sounds. Like I told you, as a basic level, it's hard to know it's hard for me to tell you this is a normal sound because I don't want you to focus on that. Oh, I need to find my water. Sorry, y'all. Yawning hit early. So I want you to focus more on your assessments, your abilities, your training, besides trying to learn these heart tones and sounds of rhythms and all that, because that's not as important as a basic as it, that needs to be later on. Oh, look, here are some of your pulse rates for ages. So again, these should be about the range that we went over the other day. A normal one for adults, 60 to 100, depends on, I like to say this, depends on what part of the region of the US you're from. If you're from a healthier, more fit area, it's going to be a little bit different versus from the South, it's probably going to be like that. I'm just straight up. And again, the younger the patient, the faster the beats. Record those because they could be like this, be like, bro, that's a big old dude. And then when you realize you start talking, you're like, man, that kid's 16. What the hell? What's he eating? So remember that also on your assessments, your age is important too. So you can be able to assess them and get your adequate rates. Oh, there we go. Let's see. So we're going to talk about pulse quality. Describe a stronger than normal. It's bounding. A pulse that is weak and difficult to feel is described as weak. All right. So if everybody knows how to check your pulse on yourself, if you will reach over to one side or the other, I don't care if you're right-handed, touch your left wrist, feel your pulse. That should be a normal working pulse. If you have trouble finding it, feeling it, I promise you an idea, you're just not feeling in the right spot. Don't cheat and check it on your Apple Watch and tell me what it is, but just pay attention. Feel the rate. Now, when you're laying there or you do something, you're like, you can feel your chest beating a little bit harder. Feel your wrist at that point too, because you're teaching yourself what these feel like. So weak and thready, it's just like, ooh, ooh. It has that beat to where you're like, bro, you gonna die or what? Because they weak. Your elderly, your geriatrics are gonna have the more of a weak pulses. Your sicker patients is the same thing. I tell people all the time, touch your patient in a very professional manner. Let's get that out there. Always feel for a pulse. I like to do it every time I shake their hand. It makes people think that I'm trying to hold their hand, but I'm holding their hand with, like I shake with my right hand and I reach over with my left hand and I feel their pulse. And they think that I'm holding their hand. I just want to get an initial rate and rhythm, rate and quality. Is it good? Is it going to beat? Or do I have to get hot and sweaty and work? It's really what I need to know. Some of your rhythms. So you can have regular. So what? I'm trying to figure out how to go through this. So the easiest, I'm just gonna leave it what it shows. So an interval between each contraction should be the same. The pulse should occur at a consistent, regular rhythm. That is called a normal sinus rhythm. If it is irregular, it's either gonna be super fast or late, or depending on where it's beating in the heart, what note it's hitting. It could be, you know, an earlier late beat or an extra beat. If they miss a beat, it's the same thing. So you can have a irregular, regular heartbeat. So it's irregularly regular heartbeat because that is consistent for you. If you have like a fib, there's gonna be, that is a irregular heartbeat, but that is regularly set for this patient. They're gonna know that if they have, you know, AFib or anything like that, or they're just diagnosed with this off the wall like leaky bach, and you're just like, I'm sorry, you got what? Bro, I'm just the basic. Sometimes I like to mess with people, especially starting IVs. Be like, bro, I don't know what you're talking about. I just got my patch like yesterday. You're my first 911 patient. Well, it kind of takes the stuff off of them, and they're not like, oh my God, you said what? And as you try to start an IV on them, you start shaking. It's kind of cool. Watch their attention. Pretty neat. But get to know your patient, see what's going on, check with them, ask a lot of questions. So Tamara says that PVC amount is weird thumbs. Yeah, so in PVCs, that's preventricular contraction. That's PVCs, you got PJCs. It's so there's all different kinds. Tamara, is yours irregularly? Like it's every now and then it's a 1, or it throws 2 PVCs every now and then? Or is it just consistently throw a PVC every now and then? My computer says my internet connection is unstable. That was nice of them to tell me that. All right, so on blood pressures, again, depends on what part of the country you're from. Just every now and then. Yeah, Tamara, you control that by medication, food, or is that just something they just keeping an eye on? I'm just being nosy. You don't have to answer. It's okay. Sorry. That's the clinic coming out in me. So blood pressures. So this is the blood that's against the walls and arteries. My 13-month-old baby is complete heart block. 6 to 12 months is average heart rate. Hey, Rose, I'm sorry, love. Man, that's a lot. Best wishes to you. Hammer, good deal. I hope they keep an eye on it. Maybe some time it'll change it. All those spills later down the road, they'll put you on it. That is great news. I'm glad to hear that, Rose. So on your blood pressures, that's the blood against the wall of the arteries. Blood drops. A drop in blood pressure may indicate a loss of pressure. Loss of, and I mean as in fluid is creating the pressure. You could have constriction, dilation. If you're scared, you know that you're going to have that fight or flight mode. Your blood pressure is going to change. Traumatic news, situation, all that is going to affect your blood pressure. What you eat, everything. So, I mean, a lot more people than you think are on blood pressure medicines just because of the crap that's in our foods. It's not because they don't have a healthy lifestyle. I mean, I know several runners that are on blood pressure medicines, but it's hereditary, something that they can't help. So if they have blood pressure problems, it's gonna be related to a cardiac issue no matter what, because that's where it all comes from. That's where it starts, that's where it ends. That is the ultimate final get-go of your blood pressure system. Let's see here. Decreased blood pressure is a late sign of shock. Abnormally high blood pressure may result in a rupture or critical damage in the arterial system. Because, you know, too high can be super, super dangerous, and too low, you can cause a catastrophic event. So keep an eye on that. Let's see, hang on, I'm trying to read a note that was sent to me. lost train of thought. Sorry, I can't multitask tonight. I'm extremely whooped. The blood pressure cuff with a gauge can, uh-oh. Hang on 1 second, y'all. My computer just decided to shut down my Microsoft. So stand by. I will get back to where we were. And it tells me welcome back. That was mighty nice of you.
I was gonna say, if you can't get it up, I have the PowerPoint pulled up.
Well, I hope. There we go. Let's see. Can y'all see that now?
Yes.
All right. I don't know what went down there. All right. So a blood pressure cuff can be used for numerous things. You can use it for a pressure bag on your IV. You can use it to tampen out a blood, like an arterial bleed. You can use them to break in cars. No, don't take any ideas. But sometimes the police will use a form of a blood pressure cuff to get into a car. So, but they're double insulated and they have an outer shell. And it's kind of the reason why I say the outer shell is it kind of keeps the funk off of it. You know, they can also get contaminated with blood and, you know, body systems and all that too. So that's just another thing. But they have a one-way valve, and then a little pressure gauge. So the pressure gauge, if nobody's ever done, not talk over myself. Where is it at? All right, so put it on like that. There's a little sign. I wish, my actual blood pressure cuff is downstairs and my trauma bag downstairs. So there is a actual this little right here. Where's the mouse? Right here shows there's a line that the artery runs on the inside of the arm. And then there's a little spot that it comes around in here and circles. So this is your brachial artery right in here. You want to align that right in there. And you want to put that on there kind of tight. Now they have multiple sizes. You can go down to pediatrics. You can go down to an adult size. And then you can also go up to even like massive, like I call the big maroon ones. I mean, they some big cuffs. So you gotta fit it to the right size for the patient. If it's the wrong size, you're not gonna get the right reading. You prefer it to be on bare skin because baggy clothing, uniform shirts, long sleeve shirts, they can cause some, you know, misreadings there. So you put it on, you want to pump it up to a certain point, depends on your until you stop hearing heart tone. And then once you do that, you start slowing it down until you stop seeing it bounce again. So that gives you your blood pressure cuff, blood pressure reading. We will strictly go over that a lot in the boot camp. Here is your regular, normal range for blood pressures. Hypotension is blood pressure is lower than normal. Hypertension is higher. I would remember those two words, the hypo and hyper. Remember, we can break them down. Please don't make me go through that class again because that was a traumatic event for me, trying to break that stuff down for y'all. But the hypo and hyper is very important so you can know which one is which. But again, table 10.7 is the chart that will help you out on the different ranges. I have never in the field checked the blood pressure on anything below 2 years of age. I don't even know if they still recommend that anymore because I don't have a cuff that I've ever worked on a truck that's smaller than that. Share your neurologic system. So we want to check them as we're doing our assessment, head to toe assessment, continuous, talk to them. what's going on. Did we notice a mental change when we started asking questions from the initial point versus to where we're at now? Has anything changed? Is there potential for a head injury? Do they have, were they involved in an MVC or MVA, depends on how y'all recognize them, vehicle collision or motor vehicle accident that caused potentially has a head injury, or did they have a syncope episode that caused them to slip, trip, and fall? Is there any dizziness that could be related by medication? But we need to know all this as we continue our cycle on doing an assessment. I like to continue to ask questions. I ask random off the wall crap, doesn't really matter to me, but it keeps the patient's attention. There are times you get sidetracked and you get focused in on something. That's cool, it's no big deal, but make sure you try to keep the patient's attention. And the reason why is you're looking for that mental change. If the mental change does, if you notice that, we need to note it this time, who, what, when, where, and why, because when you give that patient off to somebody, they're going to ask the same questions. When did you note a mental change? What was he like when you first arrived? You want to evaluate the consciousness and orientation. Not do they know what is up and down, left and right, but do they know what's going on? Do they have a grasp of what their surroundings are, what they've been through? Can they keep up? Are they able to stay awake? Do they have episodes of syncope and then they come back around, or they blacked out and didn't regain consciousness? Using the AFPU scale is very appropriate. If y'all don't know AFPU, this is alert, verbal, painful, and unresponsive scale. Everybody falls into one of those 4 categories. On every assessment that you do, it is very good to always include the AFPU scale in your regular notes, patient assessment. And the Glasgow Coma Scale score can be very helpful in providing additional information. So that is a GCS. Do y'all know how to get your GCS? Anybody? Euler. All right. I'm gonna take the quietness as a no.
Never lie to you, no.
All right. So stand by. Let me grab my notes from the other desk. I tried to put these in last night, but when I got to the hotel, I think they were having a party and I could get zero concentration going on. So I just said, screw it. I'll talk about it later. So you can get a dead person gets a 3, period. Okay. And the most awake, alert, and oriented gets a 15. So you have eyes, verbal, and motor. So let's count this. I think I can draw on here if I can find my key. Stand by. I'm gonna see if I can do this. All right. So this box, here's our box. That looks like crap. So we're gonna have eyes. Holy cow. Verbal and motor. All right, so then you have 1, 2, and 3. That's a 3. Y'all know, don't ask no questions. Y'all just take that as a 3. All right. So eyes, verbal, and motory. All right. So for each one of these, and why is my mouse disappeared? I don't know where my mouse went. I don't know why my computer does this sometimes. Well, it's not what I wanted. Oh, there it is. Stand by. Don't go nowhere. Don't know why. Just see. There it is. All right. So here we're going to have You can, so a dead person gets a 1, 1, and 1. So that means that they do not open their eyes, they make no sounds, and they make no movements. All right. So to get a 2 for eyes, you have to have opened eyes in response to pain. You do make sounds when spoken to, and extension to painful stimuli. So if I'm to reach up and rub on their collarbone, will they flex to or flex away? It's extension. All right. So then if you get a 3, you're going to open your eyes in response to voice. You are verbal, your response to words, and motor is abnormal flexing to painful stimuli. So you get a 15 out of the best that you can get, and then you work on from there down. So if you know that, yeah, get rid of that bad drawing, my bad, bro. So the worst that you can get your GCS is a 15. Now, knowing that, you each, I'm gonna send y'all in Discord something better so y'all can get that situated and y'all can better understand that chart, because I have a whole chart that I can show you guys. So what's this say? If a person obeys commands only on the right side, they get a 6 for motory. The scale also accounts to the situations that prevent appropriate testing. When specific testing having form. Never mind, that's not what I want to do. So I can send y'all something here in a little while about how to do GCS and judge them for everybody. Checking the pupils, we want to know, here you go, we're going to skip right to this slide. I want to know if they're equal, reactive, and round to light. So this one, those are all constricted pupils. You will see dilated pupils and unequal pupils. So this right here, some people live with blown pupils on each side every day. Some people may actually, this may be a fake eye that is not reactive to light. And this one right here may be because they've been a light, and what they want to do, they want to dark so much that they want all the light that they can get so they can track really big. So they're trying to suck in all the light so they can see with their regular human night vision. This one right here could be you want to, like, if you're super, super bright, everything constricts because they're trying to get all the little sun as they can because it's so bright. It could be signs of a head injury if they have C, one side or the other. So if this is her right eye, means they have left-sided brain injury. They have a left-sided TBI that is causing this right here to function. Because remember, the left side controls the opposite side of the body. So that's a big thing. So just if you recognizing what is what may give you signs of some deficiencies as they go down the road on what is wrong. I don't know where that one came from. A small number of the population exhibit unequal pupils all the time. Let's say abnormal pupillary response can indicate altered brain function. We talked about that. Could be a TBI. Trauma and strokes are your number one thing that you're going to see. You can have a blown retina, and that's where you just see nothing but dark space. You don't see any of the color. I mean, it's very like, oh, it's dramatic. I can promise you, the first time I saw it, I was like, what is wrong with this person? I don't know, but I don't like it. Certain drugs can do that. Certain toxins, I don't recall which one can do what right now. It has been a hot minute since I've looked at that, but they can also mimic blown pupil signs. So Pearl, this is very important that you know this mnemonic. Pupils equal and round, regular in size and reactant to light. That is, you can use that at any point in time throughout your patient assessment to make notes for yourself as you pass things on. And that way also, as you're going back to make notes, you got everything written down. Even if you just write, Pearl written down on your glove or your tape, and you just circle, pupils were equal and reactant to light. So you circled E and L. Well, something else was wrong, and you were doing your assessment because you were like, they weren't really round because the left one was blown. You're going to remember these things. Regular in size, no. you'll note that in your reporting system to document patient care. Check for vital muscle strengths and weaknesses. Basically, we're gonna do like a stroke exam. I've been to the doctor with like, hold your arms out in front of us. Don't let me push your arms down. Now push against me. The same thing as we're just checking that they have motor sensory to their ×4. So each arm or each leg, there's 2 of them, so that's ×4. So pulse motor and sensory, so you can have PMS and all 4 extremities. But I want to know, is it painful? Why is my watch vibrating? Okay. So I need to know what position that is. If they're able to, their right arm is drooping and they have no function, but they're also talking like this out of their right side of their mouth. Is that a stroke? Well, no, he had a TBI years ago and is not, okay, well then that's normal for him, correct. So got that marked. Or if you walk up and you're like, oh God, he's having a stroke right in front of me. Will you activate the stroke line, do everything like this and that, and come to find out that's normal. I was on a truck one time, I was a basic, and that actually happened, and that was very, very embarrassing because the medic didn't take the time to ask questions to the family. They just scooped him up and left, and I was like, oh God, all right, we're leaving, let's go. I started driving. Yeah, that was normal. So make sure you do your assessment really well and make sure what the PMS is. Check that. Can they do equal grip? Grip's important too, and you can notice if there's any change en route to the hospital. Oh, it says in the notes, test for pain sensations and position and compare distal and proximal sensory. Yes, you can do that. But by the time it takes you to do all of that, you can most likely be at an ER or in the back of an ambulance doing this as you go down the road. So this doesn't have to be done while you're sitting at the patient's home side of the road with the patient or somewhere like that. So you can do this elsewhere as you're treating them and, making them better or trying to make them better, or you're trying to gain grounds as you're gaining access to ALS service if you're just a full BLS service. So think about that. Just because it's in an assessment, does it really mean that it has to be assessed prior to leaving? No, you can do it as you go down the road. It's a continuing assessment. Dynamic regions. So head, neck, and cervical spine, you want to palpate all of these areas. You want to touch them and be respectful. I have to make sure I state that because you'll notice as we go through these skill sessions, and if you use a dummy versus, no, like a real dummy, not like an individual dummy, versus a real person, you'll hear a lot of, at this point I would palpate the chest and the abdomen and then the pelvic region. Well, yes, but at the same time as you're not going to grope the student that's being the patient, because they're also learning things too. You can do this on male or female and completely be okay with it in the settings that we're going to be in. We talked about checking for the patient's eyes. We check for the sclera all the time out here. Anytime that there's an eye injury, we always check for that. Assess cheekbones. We want to make sure the earlobes, there's no noise. Check patient's ear and nose for fluid. So their cheekbones, make sure that there hasn't been any injuries. The best thing I like to do when I'm checking the face is be like, hey, bro, look at me, smile. Can you feel all your teeth? All right, let me see them. And they're like, why am I looking like this, trying to smile at you? Because what you're doing is you're checking their cheeks, their muscle tone, and can they follow simple directions? Cool, easy. So why do we want to check the ear or nose for fluid? Can anybody tell me? I snuck a yawn in while I was waiting on a response. Rebecca, I see your mic went off, but I don't know if you said something.
Yes, it goes back to the chapter that we talked about. Where they could have like,
Ding, ding, ding.
yes, head injury.
Yep. So it could be spinal fluid. It could be leaking from around the pleural space. It can come out from the ears. Nose, I have not seen. I have seen it multiple times in ears. You start to see the clear fluid coming from the ears. Chris says possibly blood, maybe a head injury. Yes, anytime that you see any substance coming from the ear, wipe it off with a 4x4, let it sit there on the side and dry. If it dries automatically in a star-like shape, it's not going to be like a perfect drawn, stenciled out star, but you'll look at it and be like, whoa, that's exactly what he was talking about. That's the star that we're looking for. That could be CNS fluid, central nervous system fluid. So just be very notable to that, because, and don't let the patient hear you be like, bro, look at that. Because they're going to be like, what you talking about? Or either they're just going to be so screwed up, they don't know what's going on, but they can hear you talking about them. I've done that. It's not cool. Just want to let you know. So the upper maximal area and the lower mandible jaw, that's important. So we know if they have a facial fracture, because if they later down the road have to be intubated, we need to know if there's any facial fractures, because if we go to stick a tube down, we have to be very cautious, and that may be something that they have to be RSI'd for, so there'd be no fighting. And then a jaw, man, bro, that hurts. I don't know personally, but I've seen it. It looks like it hurts really, really bad. I don't ever want to find out, but it's better for you to find out in your assessment versus you coming back to the hospital later down the road and be like, so what was wrong with Fred? Oh, dude, he even had a broke jaw. Did you know that? Yeah, I saw that. No, you didn't. You lie. It's okay. We all do it as adults. So any type of, I'm not going, I mean, when they say no odors in the mouth, not gonna check it. But I need to know for the smell of alcohol. You smell a fruity like substance that could also be from a diabetic's crisis. But I'm not gonna be like, come here, let me smell for a minty aroma. Nope, not doing it, bro. I'm out. That's on you. You can have your own breath. Some people get spoiled with not wearing masks and you're not smelling your own breath, but we ain't checking for that. But you want to check for alcohol. When you go to check the chest, so here's the thing. Can you assess the chest properly without it being exposed?
No.
So remember,
Only for the respiration,
won't-
right? You can check it for the
What now?
respiration.
Correct. Now you can look for up and down and all that, but you can't, I mean, you got to be cautious about where you at. Because remember, if I go, I don't know who, I heard a female poke a while ago, so I don't know who you were. I'm sorry, I don't have my mic stuff up. If I'm going to sit there and check you, and I'm sorry, I don't see your name, but if I'm going to check your chest for rise and fall, and you're at Walmart, okay, thank you, Miss Rebecca. Remember, when you go to do this, you ain't gonna be like, I gotta see, bro, no, not happening. That's somebody's mother or daughter that you're taking care of. If it is a cardiac arrest in the middle of Walmart, cool, not a problem. You have first responders, you have Walmart staff that can be like, hey man, I need you to turn around and clear this aisle, okay? So remember that. Or you can be like, we really, really need to get Rebecca to the truck because we supposed to have to dispose everything because I gotta put AED pads on her. I need to see what's going on. There's some blood coming around the chest. I'm not just gonna do this to this young lady in Walmart. It's just not happening. Now some people do it on their own, but it's not gonna be because of me. So yes, to do respirations, I can check that if they have adequate up and down. But to do I need to check for, what's it say? Check for rise and fall, both sides, breath sounds, visually inspect and palpate. I need, respectfully, need to make sure that there's no broken ribs, put my hands on it. Tamara, I got your message. I appreciate it. I don't know why I can't type to you, but I got it. You need to do that in a respectful manner and realize where you're at. Now, same thing for a guy. We can reach up and check them. We can check for ribs. We can check for the sides, but you need to do that. And now if I just pick up Miss Rebecca, yes, right there. In normal situations, she's having trouble breathing. I'm gonna listen to her breath sounds like normal. Be like, hey, Miss Rebecca, listen, I'm gonna stick the bell of my stethoscope right on the top of your shirt. You'll just hang tight real quick. I'm gonna check it on both sides, and then I'm gonna pull it out and I'm gonna stick it right underneath, just right underneath the edge of your bra line. So if it's cold, I'm really sorry. Just want to listen to you take a deep breath. Now, breathe in your nose, breathe out normal. Now, in traumatic situations, it's going to be completely different. Again, the whole realm of things have changed. I have learned the hard way. I was doing CPR on a traumatic event, and this 65-year-old lady had breath sounds. I tubed her, got everything situated. I'm inspecting the chest and all that, and I'm listening 2 minutes after I had her intubated, and I was like, I don't hear breath sounds on the left side. What the hell's going on? Check my tube, had condensation on both. Had condensation in the tube, knew I was there, was measured. I heard it in the left side, but I was not getting breath sounds because the underwire in her bra poked through her skin and punctured her lung. Granted, I was able to fix that once I found out what it was, but now on, I, Chris Wally, have a deal that when I do any traumatic event, I cut up the center part of the shirt and the bra included, but I leave it in place. I will expose the chest, but I do not remove the bra. And now I know they have plastic underwire, all this other crap, but it don't matter to me. It happened to me once. I felt like crap. The lady ended up surviving. She was cool. We got it situated. I went and saw her in the hospital and apologized for this big old tube hanging out of her chest and all that. But, you know, it is what it is. She was able to breathe and get up, walk around. But I'm telling you, if you don't expose the chest, cut the clothes off of it and look, you're going to miss something that will screw you in the long run. So again, now we're going to check the abdomen. We went over this the other day. The 4 different quadrants that you have to palpate. So we all know what tenderness and rigidity is and guarding because we've all had stomach pains. I don't know how many's in the class tonight. Let's look. If none of y'all in here has ever had the 16 that are in here, if y'all have never had a stomach pain or injury, I don't like y'all. But if you have, we good. We're all right. We're gonna move forward with y'all. So when it's, I need to know if it's tender when you assess it. Now, if I'm telling you, oh my God, I'm hurting like more than you can imagine on my right side, don't start poking on the right side because guess what's gonna happen to the other sides? They're gonna get painful too. Start on the furthest quadrant away from the most tender area. So again, I'm gonna tell y'all, we're gonna imagine like I got a 6-pack abs with the don't, but if I'm hurting on my right side, you're gonna start at the left quadrant and work your way around counterclockwise. You're gonna work your way around clockwise to the, you're gonna check the left upper quadrant, left lower quadrant, right lower quadrant, and then to the right upper quadrant, because that's what hurts me the most. Now, if you go to poke there and I'm looking at you like, you poke me right there, I'm gonna knock your teeth out. I wouldn't suggest poking right there. Just take their word for it that it's a 10 out of 10. So they hurting. So I say that as remember when you go to assess the abdomen during your traumatic events, is that you say, do I notice anything? Do I notice any massive bleeding here? No. Okay, I'm gonna assess it for tenderness, rigidity, and is there any guarding? No. Okay, cool, rock on. And then you're gonna be like, I don't know what to do next. And you're gonna go to the pelvic. Same thing. I want to check for it. Is it similar? Is it round? Does it look like it's supposed to? Does it have? If it has like this obvious bulge in it, that's not normal. The pelvic is not supposed to be bulged out like that on a normal patient. If their leg is twisted around, I promise you that ain't normal either. So we want to now in the pelvic. Does anybody know how much blood can drain into the pelvic region and not be known? Anyone? Anybody want to take a guess? You can leak 2 to 2.5 liters of blood into the abdominal cavity before it starts to be noticed. That's a lot of blood that's pooling in your abdomen. Well, guess where it's gonna go? It's gonna go one of two ways. It's gonna go up or down. Most likely in our problem, we're gonna see that crap come up. And if you don't have an airway secured, it's a bad day. And let me tell you, that stinks. Oh, Jesus, it stinks. So when we're checking for our pelvic, we want to make sure that the pelvic girdle is not fractured in any form of fashion. I tell you, the old way to do it is what we used to do. Oh, sorry. We would grab the hips on both sides, right around the hip bones, push in and down. Now, if you can just grab the hips and push in and it causes no pain, then you're fine, rock on. If your patient can able to lift their legs a little bit, and I'm not trying to tell you to do scissor kicks, but if you can give me 6 inches, you're fine. We're gonna move on to checking there. But I wanna make sure that there's no deformities in this assessment. Your extremities, we already talked about doing your upper extremities. We're gonna check for our PMS, but again, we're working from the head down on this patient, so we're gonna get to the lower extremities. Now, when I get to their feet, I'm gonna cut their shoes off too, because if this is a trauma patient, I'm not a foot person by no means, but I wanna know if there's a pedal pulse. Do I have that dorsal pulse in a foot to know that there's equal circulation? If I gotta cut them laces or I gotta cut them nice old areates off the side to get that boot off, then it's gotta be what it is. If there's a broke ankle involved in there, you may just have to destroy these boots, but you gotta get it off to see it. If there's no pulse in the foot, you have one chance to realign it to move forward. If you ain't got no pulse after that, you splint it the way it is and you rock on to the hospital. Throwing y'all some tidbit information up in there. All right, so posterior back. So when we go to roll somebody, and I know Rob talked about it, when we log roll them to put them on a backboard. You have to put somebody in charge of the head. You can't just be like, all right, ready to roll, go. No, you got to keep that in line. You want to keep them in the most inline position that we can. So during that, what's wrong? I can't get my thing. Hold on, stand by. I'm trying to get something to work on here, so y'all give me just a second. Oh, wait, I don't know where it went. So when we go to log roll them, we want to hold on to the head, and the person that's on the head calls this call. They are in charge. I don't care if it's the newest guy or gal on the department, and they just got stuck holding the head because that's what they were told to do. They're the ones that make the call. Ready? On my count of 3, we're gonna go 1, 2, 3. We're gonna roll over to the right. We probably need to say, I'm gonna roll to the right on the count of 3 first, because everybody's gonna be like, oh, okay, go. And one's gonna be pulling, the other one's gonna be pushing. It ain't gonna work out right. You want to roll them on their non-tender side. So if their right arm is fractured and you got a splint on there, maybe a tourniquet, don't roll them on the right side because that's gonna hurt. Roll them on the left side, and then you're gonna inspect the back for decap BTLS also. Run your hand down their back, starting at their shoulder blade, down to the buttocks, and make sure there's no blood. Do you feel anything? Do you see anything? Look at your glove, make sure there's no blood on it. That's how you do it. You're running your hand down a couple inches at a time. Is there any blood? No. Check it again. Keep going all the way down until you get to the end, the bottom side of the buttocks. There's no blood, no injuries. You roll them on the backboard at that point in time. You've checked the back. You will not reassess the back unless there is an injury there. Cool? You'll follow me? I know you're about tired. It's almost over. At some point tonight, we'll get over it. There she is. All right. So this is a checking your vital signs. So when we start to do vital signs, we know how important that is. We've talked about that as we go through why it's important, how it is. You're going to continually to reassess your vital signs. If it's a traumatic or a critical patient, that's going to be every 5 minutes. Use the tools that are around. I don't expect y'all to get a temperature on your traumatic patient, but if you have a pulse ox that's on your LifePak 12, 15, Phillips, whatever you use, I don't really care, but use the tools that you're accessible to. This is a portable pulse ox. If everybody's used one, they're kind of cool. Sometimes we rely on them too much, but treat your patient, not your materials, but use your tools there. If it's a non-traumatic patient, you want to do about every 10 to 15 minutes. Your pulse ox can tell you a lot of different things. Are they getting the oxygen that they need? Are they, is their O2 sats a little low? CBGs, which is your blood glucometers, they, I know basics can do that now. That is a basic skill. And Mississippi, I don't know some of the other states. I'm sorry, I don't know where everybody's from in your state laws, but you can check that. You can prick the finger, check what their blood glucose level is. And you can also give them some non-invasive medicine. If they need some orange juice, if they need a few things to get their sugar up, you can do that. It's easy. We can make sure that happens. Rock on with them. We talked about their non-invasive blood pressures. We can use the manual or the machines. Reassessments is an ongoing assessment. You can start literally once you get from the head to the toe. You can start back over the entire trip to the hospital, and you're not wrong for that. But make sure you document what you've done and where you're at and what has changed versus your treatments. Just making sure anything is there. Yeah, look at this one. This is a good one. Have anything changed? Has it gotten better? Has it gotten worse? What has? Be specific. If they say, look, the pain has gotten worse over the last 5 minutes, we've noticed the blood pressure change. Okay, well, then now we have trending data that we can keep up with to pass off. What was initially the chief complaint, and is it still the chief complaint, or has it changed? Let's see. You want to always, oh God, I'm glad I was in there. Always continue to monitor your ABCs, because again, without your airway, breathing, circulation, we're gonna have no jobs, because the coroner gonna have all of our jobs, because we ain't done nothing. If you can't bill no dead person, so it's easier to bill people that are alive, because they pay better than dead people, because I'm telling you, my insurance only pays so much for them dead folks. And some places do transport. I refuse to transport dead people. It's not my lane, not my job, and I don't like it. Management of bleeding. If it's bleeding and we can stop it and fix it, guess what? Fix it. Don't sit there and wait. Anytime that you're in our classes or out in the field and you realize that you're going through a scenario and you see the patient is actively bleeding, stop and fix it. Okay, that's highly important and very much encouraged. We will compliment you after you're done. If you don't fix it and you just watch it and you keep going on, you have wronged, and you will fail that station. So again, continue to reassess your ABCs. Make sure that their breathing is adequate. The ventilations, the respiratory rate, quality, and rhythm is there. What else is there? There we go. Reassessment of your stable and unstable every 5 and 15 minutes. For an unstable is 5, for stable is 15 minutes. That's probably most likely going to be a test question. Is your 5 and 15 minutes. Document any changes, because the reason why we want to document the changes is our trending data. So we know what is what, where has it been, have we done good things, or have we not done the correct treatment and while we've had this patient in our care. guess what, folks? Got tired of sitting in class tonight? I'm sure some of y'all enjoyed dinner and ate while I talked. Some of y'all been quiet. What do y'all have questions on? I know I only caught a few minutes of Rob, and I know I love the way Rob teaches. We teach very different, and I love it. Rob's a good guy. He's a great instructor. Does anybody have any questions on what we've covered for patient assessment?
I don't have a question about patient assessment, but I have a question about boot camp.
I don't want to talk about boot camp. I'm talking about patient assessment. No, I'm just kidding. What's up?
So boot camp, are we going to go to a center that's close by us, or everybody has to go to Nashville?
Go where?
To Nashville. What's the location we have to go for boot camp?
I'm not going to Nashville. I can tell you that. Rob put that in the Discord, if I'm not mistaken, if I saw that correct. I would have to go.
Reginald, where is your
Looking for
closest, like, where are you at?
I'm in Memphis, Tennessee, but I work at Regional 1 Trauma, ICU, CCA Shock Trauma. So I'm in Memphis, Tennessee.
So the closest locations, hang on, the list that he put up is, trying to remember where he put it. Was it in class schedule or the important announcements? Oh, I found it. It's an
Yeah, I'm
important
looking.
announcement. So there is Defiance, Ohio, Valonia, Arkansas.
Somewhere in Arkansas. Yeah.
Yeah, I think that one would probably be closest to you.
Colonia, Arkansas. That's the country.
Defiance, Ohio is K&P Medical Transport. And then you've got Rapids Parish Fire Department in Leno, that's South Louisiana. And then Vanola Fire Department, I don't know where that's at in Arkansas. But it is an important announcement, so if you want to take a gander at that. I don't know the dates. What are the dates for that?
6th and the 7th.
He said the
Oh,
7th and the 8th. It's the 7th, it's the Saturday and the Sunday. Because in the
I'm
syllabus,
sorry.
Well,
It is the 7th and the 8th. I'm sorry. I'm thinking about the hotel. I booked.
okay.
yeah. So y'all gonna miss me by a couple of days. I know y'all upset. I'm sorry. But y'all can buy me an early birthday gift. Mine's in August. I'm just letting y'all know. That's the best that I know about the boot camp. I hate to say y'all, I have selective hearing. So if I know that I'm gonna be at work, I don't pay attention. And that's bad because as your instructor and as the coordinator, I should pay attention to that. And I know that. And that's one of my downfalls. So I'm sorry. To let y'all know, Thursday night, to kind of catch y'all up, it's not I'm trying to tell personal business, but I have to do a lot more COVID testing in the evenings because of some issues that are going on here on the rig. So probably Thursday night, you will have Mr. Brandon. I know y'all keep seeing me talk about him back and forth in the Discord, and he will chime in and help out. Very, very great guy. I've enjoyed him. But I have to test COVID in the evenings because just what has to be done. So I will miss a couple, like the first hour or so of the next couple of classes for that reason. So it'll be either Rob or Brandon teaching Thursday night. I know y'all are upset. I know y'all are distraught. I can hear it in y'all's voices, but sorry, I can't help that. Anybody else? Yes, Chris, the locations are in Discord. Thanks. We had that pointed out to where it was in the important announcements. Remember, the polos are not necessary for boot camp, but they are necessary for your rides. So just remember that. There will be plenty of pictures taken. So if you don't want your picture taken those days, just let Rob know so they can take that. We will do a lot of advertising about our boot camps and all that. I don't even know where Pell City, Alabama is, Rebecca. I'm sorry, I don't know.
Well,
So,
I didn't know where it was.
I'll be in the Gulf of
either.
Mexico. Y'all
I
come on
didn't-
out to the Gulf of Mexico. Y'all swim on out here.
So who do we talk to get more information and more specifics about the boot camps?
That would be Mr. Rob. Rob will handle that information. He is the one that will handle all that.
Okay, thank you.
Yeah. All right, loves. Y'all have any questions about class related? I'm trying to get y'all the most information that I can and help y'all out. Any questions that I can help with other than that?
What does AVPU stand for again? Alert, verbal, something and something. I can't remember.
Painful and unresponsive.
Okay.
I know I got a message from somebody earlier talking about y'all printed out the checkoff sheets that I posted on Navigate. I don't know why you weren't able to get the oxygen one, but I think I emailed those out to you guys.
Yes.
But I will, hopefully tomorrow, I will try to resend that. So you can have them all. Cool deal. All right. Well, folks,
You have the-
miss y'all's faces and come on. Oh yeah, you want the code, don't you? That's important. Hang on, I put it on my slide, but obviously it didn't want to take it. So let's get right here. So what is tonight? The 27th. All right. So there's the code for the night. Oh, sorry, I'm sending that personal message. Haha, my bad. Look, we're gonna put that to everybody. All right, the code is the symbol 1782. That is the code for tonight. Don't ask me where I come up with these codes. I just bring them out of my head. That's where they come from. So that is the code. Don't forget your test will open up at 10 o'clock tonight, and it will close on the 30th at midnight. Cool deal? Any questions, concerns, problems? All right, y'all have a wonderful night. I hope y'all best of luck on your tests